It gives me immense pleasure to welcome all of you today to the 9th certificate course of ICOG. This course is on operative obstetrics. Let me just share my screen. First of all, to inaugurate this program, I would like to invite our program convener for today, Dr. Surekha Taide ma'am. Ma'am is a professor and unit head at the JNMC in Wardha. She's a teacher for the last 20 years and a convener for this excellently designed program on operative. Before ma'am takes over the stage, I would just like to mention one thing, that I would request all our delegates who are present here to attend for all the 3 days, and we will have a MC right at the end of the program. So the minimum criteria for getting the certificate is you have to attend for all the 3 days, and you will have to pass the MCQ test. Please keep that in mind, and please make sure you attend this program on all the 3 days. So over to you, Surekha ma'am, to welcome our faculties and delegates who are present here.
Thank you, Dr. Priyankur. Respected Chief Guests, Dr. Usha Saraya ma'am, Dr. Atul Munshi sir, Dr. Sadhna Taide ma'am, and ICOG Chair, Dr. Mandakini ma'am, Dr. Parag Biniwale, Secretary ICOG, all faculty, chairpersons, and participants, a very gracious welcome on the behalf of ICOG. Heartiest congratulations to Meg ma'am and team for once again spearheading a very illustrious, comprehensive program. Obstetrics is the realm in which all of us reside, and operations ranging from minor, simple to major are part of our daily routine. However, in spite of the rigorous training which has been provided to our maternal health postgraduates, there are some operative skills which our educational system has failed to transfer to our budding gynecologists. For example, like operative vaginal deliveries or breech deliveries, complicated C-section, and many other small nuances which we have to still give to our budding gynecologists. This course is an attempt to teach, to train and transfer these skills to the next generation and transform the surgical care which our pregnant mothers are receiving. I thank Dr. Meg ma'am for conceiving this idea and materializing it and inviting us both as conveners. With these words, I take it as an honor to introduce Dr. Mandakini Meg ma'am to the august audience. Madam has traveled through a very inspirational journey, and I'm sure many young participants who have joined this program will aspire to emulate her journey as the goal of their lives. She has started at a grassroots level worker, offering her expertise to district hospitals of Akola, Amravati, Chandrapur, Yavatmal, etc. And from there, with her experience, she has risen up the ladder to serve on various prestigious posts. One to mention is the Superintendent of Kama Al-Bliss Hospital. She has also been the Deputy Director of Health Services of Government of Maharashtra and advisor to the OSD for Health Department of Maharashtra, and she has also served as a maternal health consultant for UNICEF for Government of Maharashtra. So you can see that she has gone through various administrative posts and service related posts too. She has held various coveted posts in FOGSI, and from there now she has risen to the prestigious post of chair of ICOG. Madam, on a personal note, I'm very, very privileged to have you as my guide and mentor, and I invite you to kindly take forward the proceedings as the chair of ICOG. Thank you, ma'am.
Thank you. Thank you, Surekha, for those lovely words and giving the audience a reason to see how, a gynecologist from the grassroots level comes to this level, not only in the government, but also, thank you for that. It's a great honor and privilege to welcome you all to this 9th certificate course. A background is already given by Surekha beautifully, and we have the privilege of having the legendary figures among us, Dr. Usha Saraya madam, who is a patron and a special guest, Dr. Atul Munshi, our honorary advisor and a motivational person for me always, and also my friend Dr. Sadhna Tade. Now she has reached to the level of director, the highest post, that is the director of health services. So with these illuminaries are amongst us, I think we are going to have a great time. I won't, take much of the time, but I like, because there are around 600 delegates, I want to give a little brief about the ICOG, because so many people ask me, what is ICOG? Indian College, what does it do? Our people are quite aware of our activities, but I want to, for the benefit of the delegates, I want to share my screen and just show them the ICOG activities in nutshell. So welcome you all to this 9th course of the ICOG certification course, very, very popular course. And you can see the faculty here. We have a very efficient and very, very able team this year with Dr. Alpesh Gandhi. I thank Dr. Alpesh Gandhi for being very, very motivational and also always inspiring us to go ahead. And you know, because of the corona, everybody knows, I should not repeat, that because of the adversity, we came out with the best of the training, which Dr. Atul Munshi sir was just telling, that we are doing much more in this period rather than just, being, complaining all the time. And my theme was equip, educate, and empower. Surekha, you mentioned correctly that we are equipping with so many skills and educating, empowering. And I'm very satisfied with my theme that I could do justice to this theme. And as soon as the corona was, lockdown was declared, that time I have arranged all the lectures. You can see today, 9th lecture, ICOG Journal Club, so many activities online, and they are doing just beautifully, very popular activity. You can see today's program, and also tomorrow and day after, wonderful program drawn by our expert conveners, Dr. Surekha and Dr. Mitra Saxena, and all my MOCs are doing a great job. And we are running delegates, we are running so many courses, and you can join. These are, everything is on the website. If you are interested in joining reproductive medicine, fetal medicine, endoscopy, ultrasound, you please see the courses on the website, and you have the form, and you can join the courses, and it will become an additional feather in your practice, which will help us. So these are the online courses. And as I mentioned, that we started with a bang in the last May. You can see in 1 year, we could do at least 9 courses, and it is quite an achievement because people are so effective. So we had done this course in the last May, that is breast diseases, then the oncology, then we had this ultrasound, then we had domestic violence. And this course was very much in demand, domestic violence, because there was no such course. Then endometriosis, then the police PCODs with Dr. Rakesh Singh, and all our vice presidents were the conveners, and also Ragini Agarwal done the aesthetic gynecology. Contraception is another very, very favorite topic of many practitioners, and they do the certificate courses. Journal Club is one of the most, demand academic activity, where we are encouraging the postgraduate students to take up a subject and read the journal in front of everybody. And conveners are our governing council members, and we are doing a great job at the ICOG. Then we have ICOG app. I'll request all the participants to download this app, and you can see all the activities and the recent activities, calendar you can see, result you can see, everything you can see on the app. Then online fellowship is another very good activity of the ICOG. Just click on the line, see whether you fulfill the requirement, and if you are fulfilling the requirement, then go ahead and fill the form and again the FICOG degree in such a beautiful program, which is a convocation, which is the most prestigious convocation you can see here, and you get a beautiful degree. Then we had the publications. Many publications are available on the website. You can please see. Recently, we had the conference of NCD, And we are running MRCOG courses and many other activities. I can't, go through all the activities. And this is the last slide where the ICOG certificate course attendance for all 3 days is compulsory. Link for the MCQ will be given on the last day. Please note that the link will be live up to 7th May. 50% marks are compulsory to get to pass, and after that only passing only you will get the certificate. So be very, very particular about joining the course. So friends, I want to remain student all my life. ICOG's motto, and excellence is not being the best, but it is doing the best. Thank you very much. And I will like to, now it is my privilege to introduce my legendary figure, my madam, my mentor, Dr. Usha Saraya madam. Please display the biodata of Usha Saraya madam. Dr. Usha Saraya madam is known to everybody. She is a motherly figure. She is a legendary figure, very gracious personality, and she was holding all the prestigious posts of FOGSI. She was past president of FOGSI. She was past ICOG chair, where she has done enormous work, and I have taken a lot of inspiration from her. Then she is doing extensive work in the area of cytology and colposcopy. She was, the vice president of Central Asia. She was the president of AMWA India, and she has been conferred honorary fellowship of RCOG in 2012. She has received many awards, Outstanding Women Award in FIGO, Lifetime Achievement Awards, and I think everybody looks up to the madam for her guidance, mentorship, and blessings. So today also we want to hear from her, her blessings. And when I took the charge, she was there for my installation in Lucknow. So madam, please, give your blessings. Please stop sharing. Yes, madam.
Yes, thank you very much, Dr. Mandakini, for that very extensive introduction. I feel I'm, as a founder member of ICOG, I've been there since 1984, and I feel I'm not a guest. You may call me guest or chief guest, whatever, but I should always be the chief host because I'm there since the beginning.
Yes,
We've
madam.
had turbulent times in ICOG in the beginning. We were wondering whether we will survive also. It was so difficult to set up, and all the time we were compared to RCOG and saying, what are you trying to do? And are you trying to imitate? We said, no, that's one thing we are not doing. We're not imitating anybody. We're going to have a college which is worthy of India and Indian people and Indian patients. So I'm so happy to be here today to see that it has really happened that way. So I'm very happy to see Dr. Atul Munshi, also a past chairperson who's contributed a lot to the development. Dr. Parag Biniwale, a very, very active secretary who has also contributed, and so many others who have contributed to the development of this institution. They are institution builders, and I feel that's something we need in our country, to have people who will give their best to an institution. So ICOG has had a glorious year despite the pandemic, and we have covered all the topics. Mandakini and I, when we decided in the beginning, we said we will cover all the topics. And today's topic is operative obstetrics, which according to me is the key factor in saving lives. It is without this knowledge and experience, it's difficult to handle a complicated delivery case, and the life of mother and baby are at risk. And when this happens, the key person is also the trained and experienced obstetrician. Now, you know, many times it is believed that the gynecologists can be busy in endoscopy and in assisted reproduction, and they are such challenging new sciences, and deliveries can be done by the midwives or some junior person. Okay, it may be so, but once in a while there's a case which demands experience and knowledge. And at that time, what you're looking for is the key person here. And this person has to have leadership abilities because he or she is going to lead the team, handle the anesthetists, handle the OT staff, handle the supporting staff, the lab staff, the blood bank staff, and you will feel that this is the test of your other abilities also. You can't afford to lose your temper. You can't start firing people around you. That is not the way to get the best performance from them. So very gently, very kindly, very with experience, you deal with them and get them to put in their best. And in that, you will put in your best. It's the develop a skill which you have to develop yourself, and this cannot come only from books and seminars and online things. You have to have hands down on that case to do it. So this is a very important subject that we are covering, and if you want to bring down the maternal mortality, then this topic is of utmost importance. You know, your life and your experience is something you build up yourself, and you have to be aware of what you want to build up. And this comes in a slow and steady manner, and it takes time. So I feel this course is going to help you. And by Saturday evening, you will have developed that confidence. You will have developed the skills, and you'll be itching to go back and use it. And you'll remember my words that I must keep calm and I must get the best performance from my team to show good results. What do we want to do eventually? We want a maternal mortality to be an occasional case. Once in a while, things happen, go wrong, and you lose a mother. There should be no figures, so many per 100,000, and we are bringing it down, and what we are doing. I know occasionally it might happen, but in modern medicine, with all the facilities that are available, it should be, in fact, a very rare thing. So this skill is also going to get more and more rare, because you're not going to see all that much. So when you're posted in a hospital which has a high mortality rate or a high difficult deliveries rate or referrals which are there, consider yourself lucky. You are getting very valuable experience and make the most of it. So I'm happy to be here to participate in this. I wish you all very good luck, and I'm sure you will benefit tremendously from this program. We have an excellent faculty of experienced people, and the discussions I know at ICOG webinars and all are in a very friendly manner. You can ask any questions, you can discuss your own experiences, and you will have a happy 3 days program. So wishing you all luck, happy to be with you. Wishing Mandakini and Parag and all the other ICOG people, you've had a very good tenure. You've done your best. You've given your best to ICOG, and we look forward to seeing you continuing with your work. And especially thanking Dr. Atul Munshi. I was in his academic council at ICOG, and he brought that spirit of academic excellence during his tenure. Everyone is known for what they bring to the institution during their tenure. And missing Dr. Alpesh Gandhi, I was going to say that he, with his charm and with his popularity and with his dynamism and carrying everyone together with him, has made pandemic a very unusual and unforgettable year. So it will be remembered as something, a very special year for us. Thank you so much, Mandakini, for calling me.
Thank you, madam, for that very, very inspirational words. Please mute everybody, because there is a lot of sound coming from the background. Now, please display the slide of Parag. And Parag, I'll request you to please introduce our chief guest, Dr. Atul Munshi.
Thank you, Dr. Meg. Good evening, all. I bring greetings from ICOG and welcome to this very, very interesting 3-day certification course on operative obstetrics. First of all, thank you, Madam Saraya, for always being there for us. And I cannot forget the fact that my first affection with the ICOG started when you were in the chair, and as a very, very young member, you had given me permission to help your secretary then, Dr. Sanjay Gupte, and that is how somehow I got attached to ICOG since then. So thank you for being there always. And it gives me immense pleasure to introduce somebody whom all of us have adored for many, many years, and it's none other than Dr. Atul Munshi. Dr. Munshi has been ex-professor at the NHL Medical College. He was chairperson of ICOG in the year 2014, and he had done tremendous work as convener of Academic Council of ICOG for 3 years. And that is how the certification courses were brought into limelight during his convenership of Academic Council. He has been president of Indian Menopause Society in the year 2010, senior vice president of FOGSI in the year 27. He has done excellent work as chairperson of HIV/AIDS committee of FOGSI from 2002 to 2007. And I must say that he is one of the best teachers whom we can look up to for any problems related to OBGYN. So may I present to you Dr. Atul Munshi. Sir, the mic is yours.
Thank you, Parul. I missed Parul because he's not there. Dr. Parag, Alpesh is also not there. Dr. Mandakini has done very excellent work. And nice to see that Usha Saraya, the last moment chief guest. She is the person who has nurtured the ICOG as a child. Nozer also I'm seeing here after a long, long time.
Hello,
Nice seeing you.
Hello,
A lot of other people are also there. FOGSI ICOG under leadership of Alpesh and Dr. Mandakini is scaling new heights. The one after the other started programs are there. And in this very difficult program, difficult time, they're given in quality academics, the FOGSI and ICOG people, and the people are always looking for that. If you just see the list which was given by Dr. Mandakini, there's a tremendous work which has been going on. Every month there is something which is going on. Operation Obstetrics, I know that it's a one thing which is not very popular among general people at now, but general gynecologist, general obstetrician, Nozer is very much known for forceps delivery and for delivering baby in cesarean section by forceps also. So we also know that obstetrics, as Dr. Doctor has rightly said, it's very difficult topic and it has to be handled very carefully. I'm sure that this whole course is going to give from episiotomy. You know that episiotomy people are taking that somebody gives it, second day somebody sutures it. But most of the patients who are coming to us on 3rd, 4th, 5th, 6th day are because of problems of episiotomy. And sometimes even lifetime problems are going to occur because of the fistula. So from episiotomy to rupture uterus and to the placenta accreta, all the things are covered in this 3-day session. Nice to see that star-studded program is there. Faculties are also very good. And I must congratulate Mandakini again and again to bring the ICOG at this level. Dr. Usha Saraya must be proud that ICOG has scaled so much height from the thing which was doodling at time when people were worried what to do with ICOG. But it has come to this stage and it's going to be going further and further. I thank Dr. Mandakini and all the people who have invited me over here, and I wish all the success to this. I'm sure these people who are going to go out from this, they will be much interested to learn more and more things in future. Thank you very much.
Thank you, sir. Dr. Atul Munshi for that very inspiring speech. Now I have the privilege of inviting our Dr. Sadhana Tayde, our chief guest for the evening. Dr. Sadhana Tayde, I think she doesn't require any introduction. She is amongst us. She is member of MOGS and the FOGSI. And at the moment, she is holding a very prestigious post of Director of Health Services. And now they are facing this big challenge of the COVID situation in the second phase. Sadhana, I'm very proud to say that Sadhana, when I was the superintendent of the Kama and Elbless Hospital, after me, she took over the superintendent of Kama and Elbless Hospital post, and she has developed further the Department of Radiology, and also she has done excellent work in the AIDS Society, and done the tremendous work in the PPTCT program. And she is very passionate about the NCDs. Her main interest with the NCDs. We recently had the national program, a mega conference with the help of government of Maharashtra. She in the in the helm of affairs, she has helped us. And I invite Dr. Sadhana Tade to say a few words of motivation to all the delegates. Sadhana, please. Sadhana.
Thank you very much, madam, for giving me such importance. Thank you very much, madam. You are always my senior mentors. Dr. Saraya is also there, and she has taught us so many things. Thank you very much, madam.
Stop sharing. I can't see anybody.
Yeah. Ma'am, my network is little slow, so I will not on my video, but I am here. Am I audible, madam?
Yes, please go ahead. And
Yeah.
say a few words about the
yeah. Good afternoon, everyone. I'm seeing here Suvarna also. Hi, Suvarna. Madhuri, I can't see, but then Dr. Nozar
Hi, Sadhana.
here.
So nice to connect with you.
Yeah. Madam Saraya is also there. Dr. Mandakini May. We can't say anything about her. Really, madam, you are doing such an excellent work. Very good. A nice conference of NCD, which was the most neglected subject, but you dare to arrange such a good conference of NCD. Thank you very much, madam. Then Dr. Alpesh, I can't see, but he must be there. Then Dr. Atul Munshi, who has just spoke, Dr. Reshma, all the faculty members who are present here, and all the delegates. Most of the delegates are from Maharashtra Medical Services. Our medical officers are there. And I am very thankful to Dr. Meg for arranging such a wonderful ICOG this lecture series, because that will help our medical officers from the basic things. All the subject whatever I have seen and which are covered in the lecture series are very basic, but at the same time the most of the subjects are advanced also. So they can these lecture series will give them more information as well as a good knowledge. And I think after doing this lecture series, most of the people they will gain knowledge from this lecture series, and I hope that they can work very efficiently at their places. Madam herself has done so many sections in under local anesthesia, and really I admire her, because at the PSC level or at the rural hospital, we do not get anesthetist also. And that time it is very helpful. So, madam, I really admire your work. You had worked at the ground level as well as now you are heading such a prestigious post of ICOG president. Congratulations to you once again, madam. You are doing very excellent work. Thank you all the faculties for inviting me as a chief guest here. Thank you all. And ma'am, may I take your leave because I have one other meeting. So
I know.
thank you very much. But I will be there in between and I will attend all the lecture series. Thank you very much, madam. Madam Saraya, thank you very much. Suvarna, we'll meet again. Thanks all the faculties. Thank you, madam. And best luck to your conference. And I hope that my medical officer will gain a very good knowledge from this lecture series.
Thank you, Sadhana, for deputing so many medical officers, because they are the one who are going to actually gain and give the services at the rural level. Thank you very much for coming at a short notice. And I think I hand over. Now I want to introduce Mitra. Mitra, our convener for the program, has done a beautiful program. Everybody is praising. Mitra, you have done a wonderful job. Mitra is a senior consultant in Rewari, Haryana, And it was my privilege to visit her center to recognize her ultrasound center. And since then, she has got that ultrasound center. She is very active member of FOGSI. She was the president of the Rewari Society, and she now she has become the chairperson elect of the Practical Obstetrics. A very wonderful person, very friendly person, and also a great academician. I can see her all the platforms. So all the best for your future chairmanship. Mitra, please, now you can take over the session, and we are getting late by 5 to 10 minutes. Mitra, please say a few
Yes.
words as a
Yeah.
Say
A very good evening. A very good evening to every person who is here, all the most respected seniors and all the faculties and all the attendees. At the outset, I want to thank Dr. Mandakini Meg, who is just like an elder sister, to hold my hand and bring me in such a wonderful fold. As Dr. Parag has said, ICOG is a wonderful platform, and I thank you. And as all of us know, including our convener and everybody, and as Dr. Sarya said, that operative obstetrics is something which is the foundation for all of us. I will not stand between us and the program. I only want to say one thing, that I am from a small city. And for me and all the colleagues who have joined today from smaller cities, I'm sure there are some very, very unusual topics which have been chosen specially so that when we people who are alone by ourselves, we will be extremely benefited. Topics which are no longer even taught in the medical colleges are obsolete skills. So this is a platform, friends. Please join all the 3 days. The ethos of our operative obstetrics, this 3-day course is based on let us have excellence in our practice with the experience and evidence of our esteemed galaxy of faculties. So topics like cesarean section under local anesthesia, destructive operations, tough situations, interesting panels. So I fold my hands in welcoming everyone. I'm glad that you all will be sparing your time, and I really hope this program is going to be value for time. Thank you so much. Enjoy the 3 days.
Mitra,
Yes,
one minute.
Yes.
1 minute, I want to say.
Yes.
Very important point here. I want to say that all our 8 courses, we have restricted our to 500 to 600 people. Archana is there, we restricted the ultrasound. I said, बाप रे इतने लोग आएंगे तो certificate कैसे देंगे, exam कैसे लेंगे? And to my great surprise, Madam Saraya, I want to inform you, we got 1100 registration for this course. This itself speaks volume about the quality of the course, the faculty, the ICOG, which has gained so much of prestige, and the reputation of being the best in the academics, and it itself. So I really thank everybody, all the faculties, all the esteemed guests, that you are giving value to our ICOG program. So this is coming from me and from my Parag secretary. So now please go ahead with start the program, please.
Madam Meg, before Mitra starts, there's a question raised by somebody because they are not able to log in, and they are watching the program on YouTube. So will they be eligible to apply for exam? I think we should allow them to appear.
They should be allowed. May I ask one question to the link provider, Dr. Amit? Are you here, Dr. Amit? Because I
yes,
don't know. So how many people are there in this forum? 1,000 you said, no? 1,000 people?
5.
No, we wanted 1,000 here, no?
Ma'am, right now we have 529 participants.
No, we should have capacity of 1,000 so that they all can get a link, email addresses, na? On the Facebook, how they are going to get the email addresses? Because email addresses are very important.
Ma'am, lot of people are wanting to join something. You have to go getting messages.
YouTube, it's on the YouTube.
So let them watch on the YouTube, and then we will allow them to answer questions. That will be better.
Okay. You do something, Amit, and enhance the capacity. Amit,
to take over.
Yes, ma'am.
Thank you. We come to the end of the inaugural session of this excellent ICOG certificate course on operative obstetrics. So we move on to the first scientific session, the so day one, the first session that we are having today. And I would first of all like to invite the chairpersons of this session, Dr. Anita Singh, ma'am. Ma'am is the ex-professor of the Patna Medical College. She is currently the vice president of FOGSI, and she has been a past president of the prestigious Patna OBGYN Society. Welcome, ma'am. With her to chair this session again, we have Dr. Parag Biniwale, sir. Sir is a senior consultant OBGYN in Pune, currently currently the secretary of ICOG, the ever dashing and ever smiling personality. So welcome, sir, to this platform. And we also have Dr. Archana Baser, ma'am. Ma'am is again a vice president of FOGSI currently. She is the organizing secretary of AICOG 2021 going to be held at Indore, which we are really looking forward to. And she is a AICC RCOG West Zone. So welcome Archana ma'am. So I welcome our esteemed chairs of this wonderful session. So I would first of all like to invite our first speaker, Dr. Sadhna Gupta ma'am. Ma'am is a FOGSI representative to Suffolk. She is the ICOG Governing Council member. She has been a vice president of FOGSI in the year 2016 and a chairperson of FOGSI Safe Motherhood Committee from 2011 to 14. She is a founder president of the Gorakhpur chapter of ISOPARB in the year 2020. So welcome, ma'am, to this platform. So you will be delivering the first talk of this prestigious certificate course, and the talk is on Episiotomy perineal tears. So the platform is all yours, Sadhna ma'am.
Thank you, Priyanka. And first of all, I owe a big thank to Dr. Mandakini, Dr. Parag and ICOG team, as well Mitra and Surekha, a very dear friend for this beautiful program. And it is slides are visible.
Yes, ma'am, they're visible and you're audible too, ma'am. Please go.
Yes. So with course, and it starts from episiotomy and tears. I bring greetings and first of all, let us pray for every safety and health while we are passing through most difficult crisis of our time. So if take the integral part of integral part of obstetrics and integral part of any care provider which will advise. But actually the simple things have been made very, very complicated and difficult in 21st century, and it's been become a hot controversial topic in time. Maybe it is realities, nuances, strong NGO presence and evidence as well. However, episiotomy status has really changed from routine. Yes.
Ma'am, your voice is not clear. I think there's a net connectivity issue. If you don't mind.
I will stop my video.
Yeah, that will be better.
So it's better, Priyanka?
Yes, ma'am, much better now, ma'am. Please go on.
So episiotomy status has changed from routine. Just make episiotomy simple, life simple, and the medicine should always be simple. So these are few pictures. It is from my book, Step by Step Vaginal Delivery. It is one of the own kind of book which is focused on vaginal delivery. And this episiotomy picture, which you say, one's first step in wisdom is to question everything, and one's last is to come to terms with everything. So episiotomy was first described by Scottish midwives in 1740, and in 1920 produced. It is reduces perineal trauma and ended use of episiotomy. By 1990s, it considered integral labor. What is episiotomy? Surgical incision which made into the perineum to avoid excessive distension vaginal tissue, perineal vulva, and thus protect against severe perineal injury. We usually form medial lateral episiotomy, though there are 7 types of episiotomy, and since long we have been part and of our practice. Since 83, there has been question routine use of episiotomy room, and now the is for active episiotomy room. However, I demonstrate to for audience that few studies in Finland says that laceration tripled in with episiotomy number. So these benefit of episiotomy, it trauma to the head, of repair, improved womb, preservation of muscle and facial of pelvic, protection against future sexual dysfunction, anal specific injury, and prevention of distortion. And the risk, it can extend to 3rd or 4th degree. It can have the narrow introitus, maybe complex like blood rate and no evidence, like no evidence for less evidence of pelvic organ prolapse or anal sphincter problem. These short-term effects, these are the long-term effects. But what I actually want to emphasize that it is the selection of the patient that this patient needs episiotomy. Secondly, the technique of giving episiotomy and doing episiotomy, which actually enhances or reduces complications as well as the advantage. So WHO recommends around 10% or less than 30% episiotomy in laboring women. But observe that liberal episiotomy is unfortunately very common both in under-resourced as well as the developed countries. Cochrane review report that routine use of episiotomy has no benefit and potential for outcome. And ICOG 160 says that we should go for restricted episiotomy and not routine and very high incidence of episiotomy in the birthing process. And also concerned that in episiotomy or high episiotomy not prevent pelvic floor damage. So this background and the question of placement of episiotomy in operative obstetrics. Now this is very important paper. I want to share all the people who are here. Paper Western High World 2002, it shows that 60% of final residents have never attended class on episiotomy or pelvic floor. Out of 50% have already featured a 24 degree aspiration. Only of that 20% were supervised by senior person. And this is the experience and the reason which Usha Sarai was like pointing to, and it is a question where all of us answer the pro this Sureka received going to play a very important role in doing right tech super and build confidence that they do good obstetrics. So coming to technicality of episiotomy, we have to learn what are the women who are prone to have the perineal laceration, and these women episiotomy, select episiotomy. These are criteria because they have the perineum untried horns. Women having short perineal length, this fact is so many ignored. The women short perineum are liable to ragged tear or 4 perineal tear. Excessive weight, all weights ultrasound estimated plus minus 500 grams, but we have the accurate height of the fetal, and you can prolong second stage before assisted delivery and when there is high risk of shoulder dystocia. So we have to observe the patient, we have to build the tray for the brilliant obstetrician. So the indications, the very genuine indication is the second labor for stress for having meconium in second of labor, no way avoiding me. To see perineal to imminent, you of course give the episiotomy. You give the episiotomy for second labor when the mother is exhausted or having an high risk situation, so you want short in the second stage. In assisted vaginal delivery, and to obtain more room for optical maneuver, like second twin breech vaginal delivery, which is again it is out of the way, but we sometimes have to deliver at least the second twin in breech vaginal delivery. So choose your patient well. The anatomy, the cornerstone, surgery, it is also few to know this we are through advanced going to by cutting those muscles, and this is the perineum awareness. Then the intrinsic external and the intrinsic muscle. Now, second thing is to give it episiotomy. If too early give in the infection and sometimes is not successful, and if too late it is not fulfill its purpose. The timing of episiotomy that head is in plane +2 before crowning of head to be more precise when head visible due to contraction of 4 cm. I am having some noise, so please see. If episiotomy given to maximum stretching of episiotomy performed like proving very short length. Used in connection with hot delivery, I will say it is better when you apply and lock it. When you are not able to correctly lock the blade, then the episiotomy doing cesarean with episiotomy is a very, very sorry fix. And then if the patient is under, if it's okay, usually you take 1% lidocaine, sometimes at first, but analgesia should be there. There are many varieties of video and all know as patient good to good heal, post-op pain, approximate, but most important problem is the midline extension, third and fourth perineal. Medial, it is a little more difficult, more blood loss, but got many advantages, but the recent understanding has stopped. So these are the muscles which we cut perineal and it is and below the external anal sphincter or external anal sphincter. This is that when what in median and we do in the lateral. So now what is the recommendation? The medial episiotomy period to 1. A very important thing is change of angle, because now the angle which like gives the maximum benefit around 260 degrees, and risk of serious injury decrease progressively with increase in angle of episiotomy. And to improve protection of mediolateral episiotomy, incision should be made more than 45 degrees. And again, I say it should be done head does not receive in the uterine contraction. So this is a beautiful teaser which sharing with all the delegates that actually gives something extra. It to the demand it is. So the final angle is 30 to 60 degree, length around 70 meter, depth around 16 meter, and incision point begin 9 meter for the posterior forehead. And you do all things, there is very less for the extension of episiotomy to 3rd degree tear, which is actually objective of the skin. So this very, very important point I to emphasize. Again, this diagram shows the same thing. It should be the less laceration when you have the angle between 30 to 60 degree and good length and good depth. Only that's also. Now, episiotomy. First of all, we said the vascular and well. What are the points that don't approximate, don't too tight and lock the cell, because which cause the on tissue, these pain, and wound infection, the wound adhesions. Secondly, the stomach catgut has been replaced by rapid as pain, tissue reaction, and we take large bite of tissue with but gentle approximation. Don't multiple small high number of stitches. Always take upper labor room should like operation and all septic precautions are to be taken like skill, like all thing and person should be all properly draped. Suture material, technique of repair and skill of operation are the main factors which actually influence the outcome of episiotomy repair and which actually has put the episiotomy in a doubtful domain by the all around. The identity, the second is rapid two-gender approximation. Before starting suturing, identify what is the extent of incision and what is the depth. You have not inadvertently injury internal sphincter. If they were beginner, you can do rectal examination also. Again, I say that don't use locking stitch. If it is somewhat better, then you can use locking stitch. Otherwise, not. Beneath the lower of the when you have sutured the mucosa, leave a suture approximately cavern. Or diagnosers from vagina, we should be careful, identify, do suturing, do not approximate with the gentle stitching. Subcutaneous, it is better to do the subcutaneous stitch if comfortable. Otherwise, you can on your own. Most of the today, when the cost is very important, you really do the people are vaccine rapid. Don't have to do the stitch. It gives a very good result. I say if that the wound more still muscles in the layer, you can still one layer. After is always very important for antibiotic and as and ventilator. Actually, saying sometimes we are very like delay the antibiotic and sometimes we really misuse antibiotics. So see what is the patient condition. She is diabetic, heart patient, hand patient. Then antibiotic is system antibiotic, and I say that you are very careful. The has been not and you can use same antibiotic. So key messages: selective medial episiotomy has more benefits than routine episiotomy. Well justified episiotomy performed with timing and protect in severe restoration. And episiotomy is important component of OSs, and their difference of when episiotomy the incision angle is less and suture it is used by 20 degrees. If perfect episiotomy in all it is not beneficial, the failure to perform episiotomy when they indicate may be just detriment. This is the message I want to. It should be clear. We should have the indication, correct technique, and it should not be as an agent for critical war which has been like against episiotomy, and our obstetrician should be very, very confident enough that this need episiotomy, and they should be skilled enough to give very good episiotomy, and they will give a good signal. The activity to episiotomy are also related to use of improper technique. Coming to second part, that is perineal, that is first and second degree, I will not. But again, I want to emphasize in this world, when they want to deliver the and they don't have any change in their body, but it is going against the nature. 70% of women birth vaginally sustain some degree of perineal trauma.
I'm sorry to interrupt. Just a couple of minutes left, ma'am. If you could just
line to extensive at this time. 1 minute, but I will take 2 minutes. So it is called perineal tear because we have sometimes not or sometimes no good pressure, and it is first and second is episiotomy, and 4th degree tear are important. We should identify them and good repair them. So this is the 3rd and 4th degree tear where we see that you can have no rectal endo and ultrasound, and we recognize has been so injury. I will come only 2 or 3 important anal injury, and it should be done well equipped room with anesthesia, good assistance. The very important that to see internal and anal sphincteric muscle. They retract laterally, have to identify them, and then you stitch it either with 20 or TDS, and it will either match or end suture. This slide to share the identification of the sphincteric muscle is very, very important. You have to know, you use this retract facial eyes to identify it. Then coming to external sphincter, you have to again identify and hold it in Alice, and you can do the repair either end-to-end overlapping technique, and both are considered equal. Whatever is comfortable and whatever is the need of the time actually weighs the thing. So experienced operator, good anesthesia, good assistants, the thing. Don't forget follow up care. Always do examination and always check swab instrument and document the thing. Stool pelvic floor exercise are after 6 to 8 weeks we do in country manometrial ultrasound, but see what is your result, and want to add thought that when you have very good third and fourth perineal there, expect that always you have got the same result, because it is into nerves of the floor muscle which really have residual incontinence. In pregnancy is risk 4 years compared to all multiple to again having the tear. 95% of women sustain for overt sphincter damage. So disease and happiness are mysteries of nature. We have very limited knowledge and means. COVID time of it. Let us be compassionate and determined to give best of us to everyone. Thank you very much.
Good evening, everyone. It was really nice to listen to Dr. Sadhana Gupta. I think episiotomy is one of the most commonly performed surgery by the obstetrician, and it is an art. So she has really very well covered when to give episiotomy, how to give episiotomy, and really what all details, know the anatomy and aftercare. So congratulations, Dr. Sadhana Gupta. Excellent talk. I'm sure all the delegates would get benefited by it. And I would like to thank ICOG for giving us opportunity to chair such an important session, because operative deliveries is entirely a domain of obstetrician, and we are losing this art, and we just want that this art continues and to keep continuing, and you are reviving this art. So all the very best for the rest of the workshop, and congratulations to Dr. Tade and Dr. Mitra Saxena, Dr. Mandakini Meg, and Dr. Parag, and my co-chairs. So thank you very much, and thank you, Dr. Sadhana, for enlightening us on episiotomy and perineal tears very nicely, and well done.
Thank you so very much, Sadhana ma'am, for such a wonderful talk. And I would thank Archana ma'am for your expert chairperson comments. Thank you so much, ma'am. So I would now next like to invite our next speaker for this session, none other than Dr. Noza Sharia, sir. Sir has been a past Secretary General of FOGSI, past MTP Chair of FOGSI, past President of the prestigious MOGS. He has been awarded the Fellow of Honoris Causa from RCOG, and also has got the AOFOG Young Gynecologist Award. So I welcome sir to this platform for his talk on operative vaginal delivery, Forceps.
Noza, just a minute. And Sadhana, there are a couple of questions in the question answer box. So may I request you to answer those for the delegates, please? Noza, over to you.
Parag will be taking the question at the end of the session.
No, madam. There are question answer box. There are a couple of questions which Sadhana can answer.
Okay.
Yeah, Noza, please start.
Got it. Yeah.
You want Sadhana to finish off a...
No. Noza, you need to start. She'll write the answers to those questions.
Okay.
Do I get to share my screen, please?
Yes, sir.
Priyankur, is my screen visible?
So it's visible and you're audible too, sir. And I request you to kindly mute yourself, ma'am.
Thank you. So Peter Chamberlain 400 years ago wrote, "My father, brothers, and I have, by God's blessing and our own industry, attained a way to deliver women without prejudice to them or to their infants. The obstetric forceps. These are the prototype obstetric forceps, which you can see at the Royal College when you go to London. And in spite of there being 700 or 800 instruments described, the basic structure remains the same." So basically today my talk is going to be on the forceps, and I'm going to try to talk about
their re-established role and the relevance in obstetrics today. Our instrumental delivery is being pushed towards obsolescence. Jawaharlal Nehru said the policy of being too cautious is the greatest risk of all. There was a very disturbing paper I read in 2015, and this person, Dietz, said that cesarean sections have become a political issue. This has led to an interest in forceps deliveries, even Keelan's forceps, and he goes ahead to say that these calls are ill-advised and their use should be avoided. I consider this almost a kind of scientific trolling, because this wasn't somehow based on evidence, this wasn't based on thought, and we really didn't see whether these deliveries had a place in modern obstetrics. Let's face it, the world has a problem with cesarean sections, from scarce in Africa to too many cesareans in other parts of the world. In India, we are quite happy with the fact that our national rate is about 17%. But when you look at states, you see rates varying from 8% in Madhya Pradesh to 20% in Maharashtra to 50% in Telangana. So we do have a problem. And maybe this is why ICOG in its recommendation actually clearly stated that many cesareans may be avoided if operative delivery is considered an option, and that operative delivery can achieve and expedite safe vaginal delivery for a number of indications, that the risk and complications of forceps and vacuum are low and they are both acceptable. This is level A evidence, and that a trial of operative vaginal delivery is appropriate where the clinician is prepared to stop if appropriate descent fails. I take patients into the OT if I have any doubt, and trust me, when you give the patient a trial of operative delivery, in most cases you will be successful. Now, since I'm talking about forceps and the next person is talking about vacuum, I thought let's do a bit of a comparison between the two, because at the end of the day, a purpose is the eternal condition for success. Indications, well, these are the different indications for an obstetric forceps that we had when we had published a paper way back in 1990, 3 decades ago. These were all the standard indications. This was the Western India trial of the Hayes forceps by Dr. Subhash Nargolkar, and we at Vadia were very privileged to be doing it. Now, the most common, of course, are a prolonged second stage and fetal distress, but rotation and after coming head and other such indications. I want to highlight two: prematurity and occipitosacral positions. So when you look at the indications for forceps delivery, the relative ones are basically where vacuum and cesareans would both be fine. The delay, the exhaustion, the dense epidural, the rotation. But there are certain indications in which forceps are superior. In fact, a persistent occipito-posterior position for me personally is almost one of the most important indications of forceps application. Of course, an aftercoming head or a phased presentation, caging the head in a preterm birth, as we will talk about later, and a big part of what my practice is now, and that's the instrumental assistance during C-section. Comparing vacuum to forceps, this was a Cochrane review of 9 RCTs. Naturally, vacuum failed more because with the forceps, you have a much better grip and you don't have a pop-off. But when it came to the forceps, you had more need for anesthesia, more maternal, perineal, and vaginal trauma, and a higher incidence of severe pain at 24 hours. The rates of recourse to cesarean were similar in both. When you looked at the neonatal outcomes, with the vacuum, you had more cephalhematomas, more retinal hemorrhage, and something very interesting called maternal worry. When you see your baby with that kind of chignon and it looks worrisome, with the forceps, there was a higher incidence of facial palsies. Apgar scores were pretty much the same. But let me put this in perspective. These are comparative RCTs, but by and large, the incidence of all these complications was extremely low. So why don't we just make forceps and vacuum delivery safer? Because the danger foreseen is half, you avoid it. Firstly, the ICOG classification is the one that most of us use. Outlet forceps, no brainer. I think that can be easily applied and the outcomes are as safe as a spontaneous vaginal birth. This does allow for rotation up to 45 degrees. A low forceps, which is something that many of us who use the forceps use often, is a fetal skull at or below +2, but rotation could be more than or less than 45 degrees. And once in a while, I find myself doing a mid forceps where the station is above +2, but the head has to be engaged. There is no place. We shouldn't even be talking about a high forceps. Prerequisites, well, the 500 plus people attending this webinar know about all the prerequisites. So of course it has to be engaged. It has to be vertex or mento anterior. The cervix should be completely dilated and retracted. But for me, the most important prerequisite is an operator who's skilled, who knows when to stop and when not to force the issue. So the French College also has some very interesting recommendations. I'll just go through them quickly. Routine partography does seem to be associated with a reduction in forceps use. Early correction of lack of progress by using oxytocin for augmentation does reduce operative vaginal deliveries. Early placement of an epidural does not increase operative vaginal deliveries, and the delayed pushing of for a patient after full dilatation actually reduces. So patience and giving the woman some time for descent to happen, 2 hours or 3 hours if she has an epidural and she's a primey, will also make your operative deliveries easier. Now, they say advance is progress to something better, not progress to something new. Could we not re-engineer these instruments to make them safer? Well, I was privileged to work with Dr. Nargolkar, and I was privileged to use the Hayes forceps, and I continue to do so even in practice today. Now, this Hayes forceps is a forceps which is at once a long forceps, which can also be extended, which is a parallel forceps. And I believe that the future of forceps, if we are going to reinvent it, has to be parallel branches, because less head compression, and the extendable forceps allows you to cause flexion potential. So this is a Hayes forceps application. When I do a forceps, I do use an episiotomy. In all my other obstetric work, I've almost completely given up episiotomies. Vacuums, definitely no episiotomies. In fact, most vacuums allow me to deliver a baby without giving an episiotomy because I control the delivery of the head by exception. In this case, this is a Hayes forceps. It was kind of a low forceps. It's not an outlet forceps. An episiotomy is given. I did put in the right branch first. If it's a crossed forceps, the left branch would go in first. It's always a direct application or an insertion. And in a Hayes forceps, this is what I'm demonstrating. I can extend the branches. And because this instrument actually bends, you can flex the head. And what happens when you flex the head? You get the sub-occipitobregmatic diameter of 9.5 centimeters. And you can see here how you can gently, you're keeping the head flexed, you are encouraging flexion. And once you've gotten the head down to the level you want it to go, you gently deliver the head by extension, obviously with an assistant supporting the perineum. Take your time, don't pull it out. It's when that head pops out like a champagne cork, whether it's instrument or no instrument, is when you get your maximum extensions and injuries. Now, this is for me probably one of the absolute indications for a forceps. So we often believe that the forceps does not have any absolute indications. So here again, I insert the right blade if I'm doing a parallel forceps first, but with a standard forceps, you could easily insert the left blade. A direct insertion, protect the apex of the episiotomy. And for God's sake, I've learned the hard way that if you're using an episiotomy, let it be mediolateral. Median episiotomies really only increase risk. In fact, the tear you will get without an episiotomy is always more controlled and smaller than the extension and tears you will get with sorry. I'm going to have to go to the next one. There is another advance we have to recognize now, and that's the Dr. Piley's forceps. I have more than one set of these in the different hospitals. The small one on the left I use for my sections of a 26-week, 27-week, 28-week fetus. The larger one on the right I will use for a fetus which is 30 weeks, 32 weeks, 34 weeks. Now there is an advantage to using a forceps for a preterm baby. A cage forceps was described a long time ago. This is one time I will definitely use an episiotomy to minimize the compression on the baby's head as it is delivered. This is a crossed forceps, so the left branch has gone in first, then you go in with the right branch. The advantage of this forceps is that it is more amenable to the size and the shape of a preterm baby. Our traditional forceps were for full-term babies, often with molded heads. Do not try and squeeze the handles. I've got a finger there at the level of the lock, and gently you bring the head down by flexion. Do not pull it out all of a sudden. It's a cage forceps. Keep telling yourself it's a cage forceps. I need to protect this baby's head from tremendous pressure. This fetus was around 32 weeks plus, between 32 and 34 weeks. And you can see how gently you bringing the head down, and then you deliver the head by extension and very slowly reduce the pressure of the forceps without any hurry. Again, the French College recommends that we should use more intrapartum ultrasound if there's a doubt about presentation. Posterior positions, be prepared for operative deliveries. For me, it's usually the forceps, but a vacuum could be used for rotation. The duration of operative intervention naturally is shorter with the forceps than with the vacuum, because in the vacuum, you do need a mother who's helping you with the pressure and the push. Urgency of delivery is no reason to choose. Some people say, oh, if it's immediate, do a forceps. No, you can even build up a vacuum very quickly. And there is no data to contraindicate mid-operative deliveries. So what about the objections and the concerns? Well, there are certain objections. The first problem is deficient knowledge. RCOG said deficient knowledge and incorrect technique contributed to complications. And there was a very interesting fact they put out. Maternal deaths were actually reported because of cervical tears where vacuums were done before full dilatation. And 60% of obstetricians interviewed still said that they would use a vacuum before full dilatation. You have the knowledge, but you will still do something flawed, which you know is dangerous, and that's something we have to stop doing. The other thing that we have to stop doing is when you have a failed instrumental delivery, don't combine two instruments. Now, that's not to say I won't use a vacuum to bring the head down and complete the delivery with the forceps. But the vacuum has popped off 3 times. Or if the forceps is unable to bring the baby down and then you put on a vacuum, your maternal and fetal complications both double or more than double. So you will not use instruments sequentially. They say the immediate maternal complications are more common with the forceps, and vacuum appears to reduce episiotomies. I have managed to reduce my episiotomies. More than 80% of my primies deliver without an episiotomy with the first or a second degree, and very rarely a third degree tear. And I have learned the hard way. And we obstetricians have to be humble enough to learn that if midwives could do this and do well and make patients happy and healthy, why can't we do the same? And after the urinary incontinence is the same, not more with one or the other. Immediate morbidity and mortality are the same, and the rates of convulsions and other are the same. But what are we going to do? How are we going to treat the younger generation about instrumental delivery? Well, the Swedish proverb said the afternoon knows what the morning never suspected. And we had published way back in 1991 our paper on forceps application at cesarean. I have a confession to make. I think I may not be able to deliver a baby at C-section now if I didn't have a forceps to use. And I will tell you why. If in an imaginary meeting, nature met, the obstetrician met the person who decided on evolution, the first thing we would ask for is a handle on the fetal head. And that's exactly what instrumental deliveries allow you to do. So I started off doing this under the Western India trial for floating heads. All of us have struggled with floating heads. The head bobs all over the place, more so with an anterior placenta if it's a placenta previa. I've used it for deeply engaged heads, as I will show you a little later. where you can get one hand down and then use one blade of the forceps or both. And finally, I realized that when we are using fan and steel incisions, let's face it, our ego makes us give her the smallest incision and patients love us for it because it's more cosmetic and less painful. You will not waste a millimeter of your incision space if you're using the forceps. In fact, I'll very often use a Steely's and just increase the size of the incision so that the baby just about gets out. Deeply engaged head, you can use the forceps, but in this case, I am using one branch as a vectis. You know how your hands will cramp sometimes when you're delivering a deeply engaged head? Well, once my fingers can get the one branch or one blade of the forceps below the head, you can use it to leverage the baby out like a shoehorn, and you can then guide that particular baby out with a single branch. I use this very rarely. I usually will use the other blade, so I have more control and I don't need the anesthetist to be pushing big time from above. And finally, I believe that we will teach our juniors, the next generation, breech deliveries at cesareans. I have had the opportunity of doing 2 vaginal breaches in the last few years. One was deliberate, one was unexpected. But it's the most elegant thing to do. Whether it be the Pinard's maneuver, which I just did, or sweeping the head down before the baby, or the Morisot Smelly-Weight maneuver, or as I would prefer, and as I always did in my vaginal breaches when we did vaginal breaches, an aftercoming head delivered by a forceps, which according to me is the best way of delivering the aftercoming head because there is no pressure on the cervical spine. And trust me, these are not difficult at all. My only recommendation is please use these instruments when you are not under pressure, because in a difficult case, when you are under pressure, this will definitely be a lifesaver for you, your patient, and her baby. Finally, I'd like to quote a very great teacher. I'd heard him saying this once in a class. He said, students are here to question knowledge, not to worship it. Don't accept anything just because that's how the way it was always done. I'm seeing certain green shoots, and I can at least tell you in one of the hospitals, I'm at Holy Family Hospital, we have a C-section rate of somewhere around 30. I think we've now crept up to 40, 45%. But for a major hospital in India, I think that's great. And the only reason why we do that is because we still have a reasonably good incidence of instrumental deliveries. What can we do for our juniors? There was this paper of training postgraduates. They had a study group and a control group. And they found that the failures were comparable with occipito-posterior transverse position and inexperienced operators, but there was a significant decrease in maternal and neonatal morbidity when you had a trained young person using an instrument. Less cervical, labial, vaginal tears, less NICU admissions, neonatal. And that's where I think this particular workshop of ICOG is so valuable. And Dr. Megan Parag, thank you so much. I hope you're recording it, and I hope this goes up on the ICOG website.
Yeah, it is recorded.
These next few days. So finally, non-V-SED-ART. Obstetrics is about non-V-SED-ART, not by force, but by skill. And I'd like to leave you here with this last video of an obese patient. And we are having more and more obese patients nowadays. This patient was like 110 kilos, an ophthalmologist, a non-diabetic who had a big baby, and phalansteal incision, always a benefit. Don't try and go any other incision. I wouldn't have dreamed of delivering this baby any other way. And thankfully, I use the forceps routinely, because when I delivered this baby in an obese, non-diabetic mother, when we weighed the baby turned out to be 5.2 kilos, probably one of the largest delivered in the hospital. Our forceps delivery is new. You know, I went to the London Museum of Science, and there were some ancient instruments from India. And that instrument on the left was shown there. And I can swear that that looks like a parallel forceps. The Hayes forceps is on the right. Thank you very much.
Thank you, Nozer. It was indeed an amazing presentation, and I am so happy to see the Hayes Nargolkar forceps being used, because even we are using it in our center, and it's fabulous. And I'll definitely convey it to Dr. Nargolkar and he'll be very happy to note that you are using it and you are propagating it in the way it should be. Thank you very much.
He's a mentor. He's a mentor to so many of us. Dr. Nargolkar, I think if there's one person I'd like to dedicate every lecture I give on the forceps is Dr. Nargolkar was my inspiration as to what a chairperson of a FOGSI committee should be. His committee was an inspiration of what a FOGSI committee should do. And we are only carrying his work forward. I just wish it was available to everyone in the country.
In fact, there is progress on that count. So let's hope that we get to hear a good news really soon.
Thank you.
Thank you very much. And there are one or two questions in the Q&A box. I request you to address them later. Thank you, Nozar.
Excellent talk. And as you said, we are recording it and we will be really showing it to so many people. They are so eager to see this, live talk, and it is very treat to the eyes. Even all the senior gynecologists, I can see they were all glued to the, it was so beautifully done. And I think it is just out of this world. Thank you very much for, showing us the, the art of this thing. I remember one of the things when I was new, my superintendent used to say, please stand behind Dr. Mandakini. Because once or twice while pulling, I fell down with the baby. And that was my, initial phase of, so I just remembered that incident when I started. So anyway, that is just for the humor. But thank you very much for being such an excellent lecture and giving to our students. Please carry on this.
Thank you. I think Priyankur, let's Suvarna start sharing a screen. Don't share that. It's a pleasure to introduce a very dear friend, Dr. Suvarna Khadilkar, who currently heads the Department of OBGYN at Bombay Hospital. She has been head of the department at Medical College Kolhapur. She's just recently completed her tenure as editor-in-chief. She holds the post of treasurer of FOGSI. And of course, she was past president of Indian Menopause Society. Again, we have one more hardcore teacher who's going to talk about vacuum extraction. Over to you, Suvarna.
Welcome, Suvarna.
Thank you so much, Parag, for those kind words. And thank you so much, Dr. Mandakini Meg, for having me here. And above all, I thank Dr. Nozar for bringing back all those memories of the forceps applications which we used to regularly practice in our respective departments. And believe me, as a editor-in-chief for last 3 years and as an editor for last several years, it is very, very sad that none of much papers have come up on either vacuum deliveries or forceps. There are lots on cesarean section, but none of them have come in forceps. It just speaks about the culture that or the the trends that are going on are more for cesarean section. But let me tell you, today's lecture is and the whole program of operative vaginal delivery is very much relevant, because we are all here to reduce the number of cesarean sections. So let's go back and see what we were doing when we were residents, when we were teaching students till, I was associate professor and professor. But last few years, I think all these deliveries, operative vaginal deliveries, I read one comment in the chat box that they are obsolete and they are just the, feature in the webinars. So let's not have the just in the webinars, and let's practice them wherever it is suitable. And let us all unite to decrease the cesarean section rate. So let me start with my presentation, operative vaginal delivery by vacuum and Odin. Second stage is unpredictable. Had it been so easy, it was so easy that, like movies, 3 pushes and the baby is out. So can somebody tell me how to get rid of this bar? Okay, so this is something which is not so easy. I think every delivery and every second stage is a test for the mother as well as the obstetrician. Dilemma still exists, do or don't, you know. So we have to decide, and any type of operative delivery, vaginal delivery or cesarean section we go ahead with, it definitely requires skill and training. None of the surgeries or none of the procedures can be done without a required skill and training. And let me tell you, friends, there are obstetricians who are born with the skill, and there are some obstetricians who acquire a lot of skill during their training course. So in all, we must have a well-trained obstetrician to conduct operative vaginal delivery. So we need skill, we need SOPs, we need protocols, we need right kind of equipment, we need supervision by seniors in while you are learning, and we require to know what are the prerequisites for operative vaginal delivery. Now, we have just heard wonderful lecture by Dr. Noser, who talked so much about Forceps, and so much he is still practicing. It's such a pleasure to know that he is still practicing so many of good and some difficult obstetric Forceps application. Now, last few years, if you don't have that kind of skill, sometimes people say vacuum requires less amount of skill, but no, any operative vaginal delivery, you need to be trained in that particular steps of the surgery. So what is operative vaginal delivery? The emergency or elective assisted delivery using either vacuum extraction or an obstetric forceps. That is what is OVD, or the operative vaginal delivery, and it is to mimic the spontaneous vaginal birth to expedite delivery with minimum maternal or neonatal morbidity. So ventouse or vacuum extraction is a vacuum device or a suction device used to assist the delivery of a baby when labor has not progressed adequately, or you feel that the patient mother is exhausted. She is less likely to push the baby on her own. She requires some assistance. You can use vacuum forceps to assist her delivery. So indications for vacuum could be shortening of second stage of labor, maternal exhaustion, presumed fetal distress, because all of us know if the fetal heart rates are dropping to 80, 60, we rush the patient, we resuscitate the patient and see, and then it is a relative, in fact, contraindications when the vacuum was, initially thought, because it takes some time for vacuum to build within that suction cup. But otherwise, if you presume that fetus is not doing so well, you could use vacuum and deliver early. Occipito-posterior positions to deliver the second twin if the head is presenting part, and non-conventional indications like Dr. Noser said that he could use the obstetric forceps for at the time of cesarean section. The same way you could use vacuum, some obstetricians could use it at the time of cesarean sections, and of course to deliver a frank breech. But I let me tell you, I have absolutely no experience for frank breech, or some cases I have seen cesarean section vacuum has been used, and I will further go and say that vacuum has also been used to deliver big uteri at the time of hysterectomy. Now, what is the contraindication? The absolute contraindication would be operator inexperience. If you are not trained and experienced, do not go ahead with such kind of operative vaginal delivery with vacuum. Inadequate trial of labor, high fetal head, malposition after coming head of breech, and known fetal coagulation defect, because then it will really cause serious neonatal morbidity and maybe mortality. So relative contraindications are like prematurity and intrauterine fetal demise, congenital anomalies, and sometimes if you have had a fetal, fetal scalp sampling, it's a relative contraindication, but RCOG does not say that it is a contraindication after fetal scalp sampling. The various types of vacuum devices, as you can see, in 1953, it was first time Malmstrom had invented and devised this particular vacuum extractor, and it went on for so many years. All the medical colleges, all the private obstetricians have this type of vacuum extractor, which has a metal cup with plates, traction chain attached to the plate, traction handle, pressure rubber tube, which encloses the traction chain, and the pressure of the vacuum bottle with pressure gauge and vacuum pump. But there were certain drawbacks with this particular design of vacuum. So Bird's vacuum modification of the vacuum cup came in, and he devised two cups, Bird's anterior and Bird's posterior cup for to be used for anterior and posterior positions of the fetal head. So vacuum tube here is attached to the opening near the periphery of the cup, and the traction chain to the hook in the center of the cup. The reason for doing this is that when with the Malmstrom cup, when you try to pull in and try to put traction, as you know, the fetal head takes a path a little oblique. So when you try to pull in the direction of the oblique direction, and if the the cup which is snugly fit on the fetal scalp can get, kind of the suction can give way and the cup can slip. So to avoid that, he had isolated both the things. The traction should always come from the center. So he attached the traction chain to the hook in the center of the cup, and the suction was created from a vacuum tube which was attached to the periphery of the cup. But all was not so easy, and that peripheral vacuum tube also was becoming little difficult. So what are the types of the cups? So now I'll show you different types of the cups. The soft, the silastic, plastic, Mitivac cups are available. But with all these metal cups which were designed earlier, there was another modification, and that was O'Neill's cup. And O'Neill cup also, he devised occipito posterior and O'Neill's posterior and O'Neill's anterior cup. So he was a brilliant obstetrician and very, very good, technologically sound. So what he thought was, well, there are drawbacks of each of the Bird's cup and the Malmstrom cup. So he combined more FER2, and he devised this two cups. The one on the left is the O'Neill's left, and this is the right. And there was one study which actually I had a good fortune of working with Dr. O'Neill at Subiaco in Western Australia, and I've seen how he has done his work and how he has reached this invention. And it was really appreciated, and a lot of obstetricians were using this O'Neill's cup, which had a rotating circular plate against its bearing, and a ring of traction chain slides along the perimeter of the circle. That is, how these two cups are designed. And this particular cup was studied in by Michael Thierry and all, and I have taken this from the paper where they compared Malmstrom cup and the O'Neill's cup, and their conclusion was that the more efficient lateral pull and greater maneuverability was claimed to be more efficient, perinatally safer than the Malmstrom cup model. So I think this is something which was new but not very popular across the globe. It was started to be used by everybody, but very few I have seen being used in India. These are the types of the cups, vacuum cups and handheld pumps that we used to use a electrical suction machine, but that was not ideal. I think the handheld suction is the best, and you can see the various devices and the cups which are soft, with the idea that it does not traumatize the fetal head as well as the maternal tissues. Both can be inserted well, because they being soft. Both bell-shaped and mushroom-shaped cups can be folded to facilitate the insertion, And once you place it, the proper cup placement has to be confirmed, and it is the most important determinant of the success in vacuum extraction. The center of the cup should be over the sagittal suture and about 3 centimeters in front of the posterior fontanelle towards the face. And if you have correctly applied and placed the vacuum, the success rates are higher. But it is seen that if you do not apply, the chances of successful vaginal delivery as compared to forceps are less with vacuum application. After determining the position of the head, insert the cup into the vaginal wall, ensuring that no maternal tissues are trapped by the cup. Apply the cup to the flexion point, 3 centimeters in front of the posterior fontanelle. The center of the cup should be there, centering the sagittal suture. Pull during a contraction with a steady motion, keeping the device at right angles to the plane of the cup. So remove the cup when fetal jaw is reachable. So if you can see in this picture, the steps of application, placement of the cup, and then slow and steady removal of the cup here. So these are the steps of application of the vacuum in operative vaginal delivery by vacuum cups. I think more popular are these stylistic cups than the metal cups these days, and they're absolutely available. I think accessible and available in almost all the centers. So you should get used to this kind of application and delivery when the suitable fetal presentation and position is there. The actual procedure can be with lithotomy position, antiseptic measures for the vagina, vulva, perineum, vaginal application to check pelvic examination, application of the cup as we just discussed, creating the negative pressure, traction and pull it in proper direction. And after delivery, release of the cup, the head must be completely or partially delivered with no more than 3 pulls. The head is at least begin to move with the first pull, then go ahead. The cup must not be applied more than twice. So the application of the cup must not exceed the 20 minutes. So after correct placement of the cup is confirmed, vacuum pressure should be raised to 100 to 150 millimeters of mercury to maintain the cup's position. Vacuum suction pressures of 500 to 600 have been recommended during traction, although the pressures in excess of 450 millimeters are rarely necessary. So just use the minimum necessary pressure, not too much, not too less, otherwise the cups will slip. And always traction should be applied during the contractions, and between the contractions the suction pressure can be fully maintained or reduced to less than 200 millimeters of mercury. Now this is a small Kiwi manual vacuum system demo. If you can see the flexing median, flexing paramedian, deflexing, out of all that, what we want is the flexion application. I hope you can hear the voice.
Yes, ma'am, you're audible, ma'am. Please go on.
Yeah. No, the video and audio, both.
Ma'am, we can see the video, but the audio in the video is not audible.
Yeah, that's what is a very small this thing I can explain. The cup is going to be applied in a flexion application. So the cup should not be placed more towards the anterior fontanelle, but it should be exactly 3 centimeters. The center should be exactly 3 centimeters ahead of the posterior fontanelle, and it should be applied in a flexion application. This is what is favorable, so that when you pull or more towards the occipital area, when you pull, the flexion takes place and easy descent happens and rotation happens. Now the handheld pump is being used to create vacuum. Left hand holds the cup in position. This traction has to be applied when the uterus is contracting. When you maneuver the traction and the direction, make sure that the cup doesn't slip. And if you have applied correctly and maintain the traction, the delivery is easy. And that's how the vacuum is to be applied. I think this will help the students or the trainees who are there. Now recommendations are as like, maximum of 2 to 3 cup detachments are allowed. 3 pulls for the descent phase, 3 pulls for the outlet extraction phase, and or a maximum total vacuum application time of 15 to 30 minutes are commonly recommended, with most authors advising lesser time limits. I think 30 minutes is also quite long for me. I think we should decide whether you are leading for a successful vaginal delivery or no. What about failed procedures? Why do there occur failed procedures with vacuum? The most common is the undetected, undiagnosed cephalopelvic disproportion. So it is very, very important that you diagnose the, assess the pelvis much in advance, and see whether the size of the baby and the pelvis you think there is. And of course, that comes only and only with experience. If you do many pelvic examinations, like it is your accurate assessment does come in. But there are times when your accurate assessment can go wrong, and there can be other reasons for failure, like incorrect technique, traction without having maternal pushing efforts or during contraction, upward traction prior to crowning. So all these are incorrect techniques which must be avoided. Deflexing application, like for example, if you have cup which is not applied more on the occipital side, but rather on the more in front near the anterior fontanelle, when you give a traction, the head is likely to get extended or deflexed, and in that case the larger diameter comes in along with the pelvis, and the further failure of further delivery will take place. Large caput succeedium, a large volume of scalp into cup reduces the total vacuum area, and more pronounced with bell shaped cups compared to mushroom cups. And so you must understand where you go wrong, and you should avoid that. And it is more pronounced with soft compared to rigid cups. Avoiding the problems is again same thing. Make sure that the cup is placed properly, avoid entrapment or vaginal soft tissue, know when to abandon the procedure. Practitioners must be willing and able to abandon the procedure and proceed to cesarean section delivery promptly when the vaginal delivery is not progressing normally. I have seen some of my, when I was unit head, I had seen when I used to make a surprise visit to labor ward, I had seen that the juniors or the lecturer would supervise the vacuum delivery. I had seen them give jerky, jerky kind of pulls to the vacuum to have a successful vaginal delivery. But I don't think it is advocated. Any jerky movements, you may land up in slipping of cup.
Ma'am, sorry to interrupt, ma'am. We've got a couple of minutes left, ma'am.
Okay, fetal risks are you can see here, scalp lacerations, if torsion excessive, then cephalhematoma limited. If you can see there, it is only limited to the suture line. here, and there can be subglial hematoma which crosses the suture line. As you can see in the second picture, the intracranial or retinal hemorrhages can take place. Then it will lead subsequently to hyperbilirubinemia and jaundice, and there is a higher incidence of cephalohematoma and retinal hemorrhage compared to forceps. So these are the risks with vacuum delivery: swellings and bleeds associated with operative vaginal delivery. You can all see the different layers of the skull, the skin, then the caput comes under here, the aponeurosis is here, periosteum is below that, and then the skull, and you can see the cephalohematoma is right here, the subglial hemorrhage comes right here, and the dura mater. So wherever there can be this thing, this is one baby which is having subglial hematoma. You can see the widespread hematoma crossing the suture line. Then you know that this is not just a cephalohematoma. So serious complications of vaginal, if you compare with the forceps, the maternal third and fourth degree perineal tears are more with forceps. Extensive and significant vaginal vulval tears are more with forceps. PPH is more with forceps. Neonatal, however, are more in vacuum, like whatever we just discussed: intracranial hemorrhage, subglial, subaponeurotic hemorrhages, and injury of sixth and seventh cranial nerves. Both can be similar. Cervical spine injury is more common, especially with the rotational forceps. So this is again the same picture. So how do you predict complications? A patient who's obese, high BMI, weight of the baby more than 4 kg, maybe in Indian context 3.5 could be taken, where you may predict higher complications. Occipito-posterior position, where vacuum is doing the dual duty of descent as well as rotation. So all of us know that when this double duty or the double function simultaneously is associated with higher incidence of complications. So mid cavity and rotational forceps will have higher complications. So this is the comparison. I think Dr. Noser has given a very good comparative points between forceps and vacuum. So I think I'll just talk about vacuum. There is an increased incidence of all the cranial cephalohematoma and other hemorrhages, less likely than forceps to result in a successful vaginal delivery. This is definitely true. So if you are trying with a vacuum, chances that your vaginal delivery may fail are higher. And less use of regional anesthesia, whereas for forceps you require anesthesia. Less serious maternal injury and less pain 24 hours after delivery are the advantages of vacuum over forceps. So these are the Cochrane systematic review, Cochrane database in 2000. They have done 10 trials have been included, and they have found that use of vacuum extractor versus forceps delivery was associated with significantly less trauma, and there were more deliveries with vacuum extraction, and fewer cesarean sections were carried out in the vacuum group. And however, the vacuum extractor was associated definitely with higher neonatal cephalohematoma and retinal hemorrhages. Now, this sequential applications, I'll just give one small message here, that obstetricians should be aware of increased neonatal morbidity with failed operative vaginal delivery, and subsequent use of instruments changing for, as I think Dr. Noser very nicely described, you first apply vacuum, then try forceps, again go for vacuum. This is absolutely not advisable, and operator must balance the risk of C-section following failed vacuum extraction versus risk of forceps following failed vacuum extraction. Now, we have seen both these, our traditional devices have certain pluses and minuses. So is there any other device? Have our inventions no more? No. In 2006, a car mechanic from Argentina, he devised the instrument called BD Odon device. He saw a trick to remove a cork from a wine bottle, and he devised this particular instrument for obstetric deliveries. It was supervised by WHO, and it was funded by grant from Saving Lives at Birth, a grand challenge for development. Clinical studies began in 2011, but some of the studies were to be reported in 2019. But on reviewing of the literature, somehow I could not get. There might have come with some conclusive, recommendations about this device. But the device seems very, very unique, very, very creative, and you can see the innovation there. The step 1 and the device step 2, it is kind of principle is that there you can create a layer of air around the head so that the complications of the head of the fetus are minimized. There are 4 plates or spatulae there in the machine, in the device, and there are the collar, which you can see it is slipped over the fetal head till it goes and touches the chin of the fetus, and then the air very slowly inflated around the fetal head, and then the the traction is given, and then the head is delivered. You can see in the 5 and 6 number figure, once the user pulls on the handles, sleeve, and leveraging and traction created. So this is a wonderful device that is come out. I'm not aware, I have never, of course, used it, but I'm not aware how much the literature has come through on this device. We are awaiting more trials and more conclusive recommendations about use of this. And I'll stop here because there are certain FAQs. If you want me to continue, I will continue. Let me know, Dr. Priyanku.
Suvarna, I think we are running out of time. So
yes, so I think I will skip all these FAQs which are there for the students and the trainees. So these are the post-operative cares. How should we advise for future deliveries? Women should be encouraged to aim for a spontaneous vaginal delivery in subsequent pregnancy, as there is high probability of success after first delivery. However, care should be individualized. For the women who have sustained 3rd or 4th degree of perineal tear, you may think twice before giving her vaginal delivery. The thromboprophylaxis should be given or no. I think you should reassess her after the delivery and risk factors for VT, and then if appropriate, thromboprophylaxis can be given. Skilled pediatrician should take care of the newborn, and this is the key take home. Proper assessment and evaluation of case is very, very important. And if you are not sure about the adequacy of the pelvis and the findings, do call in senior, do take second opinion before you proceed for any operative vaginal delivery. Informed written consent by the patient and attending relative is important. Choose the right equipment. A certain indication is there. Rule out the contraindications. Fulfill all the prerequisites. Attempt a phantom application before the actual application. Supervised by qualified person. Appropriate force is applied. If failed operative vaginal delivery, then abandon the procedure. Keep double setup ready for emergency LSCS. So needless to say that vacuum is supposed to be carried out in places where cesarean section is accessible with immediate effect. Thank you so much.
Thank you,
Suvarna. Indeed, it was in-depth presentation about vacuum forceps, vacuum delivery. Thank you very much. Priyankur, I think you can move ahead with the second session. Suvarna, there could be some questions in the Q&A box. Okay. May I request you to answer them, please?
Sure, sure. Thank you. Thank you all.
Dr. Anita Singh, ma'am, would like to speak something.
Yes, Dr. Suvarna, I must congratulate you for the excellent talk. You have covered all the aspects of vacuum quite in detail. And I want to congratulate as well as thank the organizers for having given me this opportunity to chair such an important session. And regarding vacuum, I think it changed the face of obstetric practice. Because when we were students, vacuum was not there. And it has made actually instrumental vaginal delivery a very important, it is a very important aspect of that procedure on the whole. As Suvarna said that nowadays we do have many patients who are grossly obese and they are having oral anesthesia. So we need more and more of instrumental deliveries to be done. And vacuum is a very good choice because we have seen the statistics. It leads to least amount of maternal trauma. Carefully chosen cases are done, then least trauma to the fetus also. And we do achieve a very high success rate. And I think it is going to stay, and we should make out all the postgraduate students well trained in vacuum extraction during their residency, so that when they go back and start practicing, they are expert at it, and that will definitely decrease the rate of cesarean section. Thank you.
Thank you. In the end, I would like to once again thank Dr. Meg, and I want to thank one person, that is Dr. Surekha, who has helped me with this presentation. That's a wonderful help that she offered me. And I also would like to thank the whole ICOG team, including Parag and all the faculties for being here. And I see excellent attendance. Congratulations. I'm so glad I accepted this and I'm here. Thank you so much.
Thank you.
Thank you so very much, Anita ma'am, Parag sir, and Archana ma'am for chairing the session, and Sadhna ma'am, Noza sir, and Suvarna ma'am sir for delivering such wonderful talks. Now I would request Dr. Mandakini ma'am for your concluding remarks of this session, please.
I think you don't require any concluding remarks. The session was so excellent by all the speaker, esteemed faculty. Nozer was, too good. Suvarna, you have made the day, and I think all the delegates are enjoying. They are having genuine questions. I think you answered those questions, and I will congratulate both the conveners for keeping such a wonderful, practical, from episiotomy to vacuum to operative deliveries, and now will be cesarean section. It's a wonderful thing, and I thank everybody from the ICOG for making it a grand success. Thank you very much. Thank you, Nozer. Nozer, thank you very much for coming.
Thank you so much, Mandakini ma'am, for concluding the session. Now we move on to the session 2 of this inaugural first day's program, and it's the session on guest lectures. So I would first of all like to introduce the chairpersons of this guest lecture session. It's Dr. Usha Sharma ma'am. Ma'am is well known to all of us. She's a teacher of teachers, ex-Director General of the Medical Education of Uttar Pradesh, Principal cum Professor of Obs and Gynae at the LLRM Medical College in Meerut. She has been awarded by a number of awards, including the Dr. B.C. Roy National Award for her eminent medical teacher by the President of India, and she has been also received the Rashtriya Ratan Award and Gold Award. So it's a matter of pleasure to have ma'am with us, and to chair this session along with her, we also have Dr. Pushpa Thorat ma'am. She is an eminent gynecologist from Amravati with more than 40 years experience. She has worked extensively in the district hospital of Amravati with expertise in high-risk obstetrics, emergency obstetrics, and maternal health. And she is a UNICEF consultant of maternity health as well. She has retired as a deputy director of health services. So welcome, ma'am, to this platform. And we also have Dr. Alka Kuthe, ma'am, with us. She's a consultant obstetrician and gynecologist practicing at the Kuthe Hospital and Maternity Nursing Home in Amravati for the last 25 years. She runs her own ultrasound clinic as well. Her specialties are Obs Gynae. She has done LLM in criminology, PG diploma in human rights and education, and the most interesting part, she is also an instrumental music teacher of sitar as well. So it gives me pleasure to welcome ma'am to this platform. So I would first of all like to welcome our first speaker for this session. It is Dr. Mandakini Meg ma'am. She is the chairperson of ICOG FOGSI. Everyone knows her. Wonderful personality. So I hand over this platform to Mandakini ma'am for her talk on cesarean section under local infiltrative anesthesia, past, present, and the future scope of it. So over to you, Mandakini ma'am.
So thank you very much for such a wonderful topic to be given by the conveners, and it goes with the session very beautifully. Episiotomy to the vacuum, to the forceps, to the vacuum, and now in the local anesthesia. And Priyankur, you just forgot to read about the biodata of Dr. Pushpa Thorat, that she has done maximum operation in local anesthesia, cesarean section in hospital for Amravati. That is how she is here chairing, and also Usha Sharma madam in the UP
Very good.
Obstetrics. She has done that kind of work, which I think the juniors and the delegates here, I can't imagine so many people are asking me, madam, is it true that you people we are doing a cesarean section in local? So now I come to let me share the screen. I am thankful Usha Sharma madam and Dr. Pushpa Thorat and Dr. Alka Kute to chair this session. I am really honored by your presence. So my topic today is a kind of a little very rare topic which everybody is talking about. That is the local infiltration anesthesia, cesarean section, past, present, and future. So cesarean section is the most commonly performed in surgery in the obstetrics, as we all know. It is unevenly distributed, around 25 to 30% is worldwide. And you can see the figures. I won't waste my time in the figures. And more than 50% is done in the Brazil and other countries, right down to the USA, which is 32.9%. And I will like to quote the national rate in India. As per the latest National Family Welfare guidelines, cesarean section population level India seems to be 17.2%. But here I like to say that in Maharashtra there was a lot of hue and cry that at some places the cesarean rate was more than 50%, and Maharashtra government wanted to take the control, wanted to monitor, and wanted to give punishment also those who are doing. And FOGSI took a stand for this. We have the FOGSI stand here, and FOGSI was very strict. They say we can't curtail the cesarean section, whatever is necessary, and they give very big letter to the. So now this GR is not applicable to the controlling the cesarean section rate, but overall the cesarean section rate is 17.2%. Now the choices of anesthesia. So choices of anesthesia are a main type of anesthesia is regional anesthesia. All of us are nowadays going for the spinal block and combined spinal or epidural anesthesia, general anesthesia, and long-acting local anesthesia, which I will be taking you in detail. So spinal anesthesia, we all know that, and it is a, the anesthetists are very expert in their anesthesia, but what is from the obstetrician's point of view is, it is a very rapid onset, little risk of local anesthetic toxicity, and also failures are infrequent. And disadvantages are the high incidence of hypotension, and monitoring is also required, and finite duration of the anesthesia. These are the disadvantages. The epidural anesthesia is preferred by many of the clinicians, and they are because of the gradual decrease in the associated risk. Continuous epidural anesthesia has got better control over the sensory nerves. So epidural anesthesia for cesarean section is generally most satisfactory when the epidural catheter is used. And it can be combined also, like provide a combined spinal with the epidural technique. But the potential problem will be, we cannot inability to test the catheter. Once the spinal is given, we can't test the catheter, and it becomes a problematic, and possibility of failed epidural is there. So these are all the anesthesia which are given or preferred by the obstetrician, or sometimes it is a choice of anesthetist also. General anesthesia can be given very quickly. We can monitor blood pressure, breathing is also controlled, and also the bleeding, clotting, and other neurological disorders can be given. But the mother is unconscious, we all know. It has got all the complication of GA, and also she cannot participate in the birth process. So these are the few this thing. So the regional anesthesia has become the preferred technique for this. But the local anesthesia has got its own place in the cesarean section. Local infiltrative anesthesia is not a common technique because it cannot be practiced by everybody. It requires highest degree of skills, it requires experience, it requires patience, and it requires a very gentle handling of the tissue. This technique may be useful in the when the general and regional anesthesia is contraindicated, and it has been used in the 90s by the UK. In India, we are frequently using in the district hospital of Amravati, Akola, and all the regional hospitals of the Maharashtra. We are using this, day in and day out. Then the use of local anesthesia for cesarean section requires highly skilled experience, I mentioned, and requires continuous counseling of the patient, and also reassuring also requires, because patient is conscious and so many times she feels baby coming out, pressure, and so many things. So you have to be very, very gentle with the patient. There are limitations. You can't put the packs. Then you can't put the big retractors. You can't keep on retracting all the time. The gentleness is the key for a smooth local operation in the local anesthesia. It can be safely used in the high-risk patient I have mentioned. And as per the ICOG guidelines, that infiltration of local anesthesia can be used in cesarean delivery when the adequate general or anesthesia is unavailable. Then also, as per the guidelines, the maternal request is sufficient reason to provide the pain relief, and use of infiltrative anesthesia being used in poor clinical state or morbidity or heart failure as these are the indications. What are the contraindications for the local anesthesia? We have to avoid the women with the eclampsia, severe eclampsia, pre-eclampsia, laparotomy, a lot of scarring is there, obesity, adnexal pathology, placenta previa, very difficult to go through the this thing and perform the procedure very quickly, apprehensive and allergic to lignocaine, and if the surgeon is inexperienced, you should not touch the patient. Now there are two types. So the second type is very popular with us, with all the panelists here, Dr. Pushpa Thorat, Alka Puthe, under local anesthesia, along with the pethidine and the promethazine, is given as a pre-medication, and that is the key of success of delivering the babies, this thing. And you can give inhalation also. Sometimes we were requiring the inhalation also. That time we were giving ether inhalation, and also this inhalation pre and post delivery we can give with the additional to the local anesthesia. Now there are different techniques of infiltration. So abdominal field block, arrowheaded field block, and Monica's block. If the abdominal field block is the most common, you can see here that we give the anesthesia from the from the umbilicus to the symphysis pubis, and it is 5 centimeters above the symphysis. And then you can have the arrow-like infiltration of the anesthesia, and which is very effective. And also, most important here, I again and again saying, and from my experience, later on Pushpa also can give some concluding remark, that the intramuscular pethidine and intramuscular this thing, the timing is very important. And when we were doing 3-4 cesarean section coming out in the middle of the night to do the local cesarean section in the local, it was on an average 3 to 4 cesarean section in a day. So that time I saw to it that I developed my own technique, that we used to give 100 milligram to start with 50 milligram intramuscular just half an hour. And I used to tell sister, please give me the exact timing when the pethidine is given. And after half an hour, you used to take the patient, and the pethidine promethazine was given at the time of delivery, and the dose should not be more than 100 milligram of pethidine. And at the table also, you used to give IV drip of pethidine. And to my great surprise, when I started doing this regime, I found at the time of delivery of the head, patient was actually snoring. And I was so pleased with my timing. I have developed my own technique of giving the pre-medication timing, delivering the baby at that particular time. And because we have to develop your own, comfortability when the patient is least and sleeping well that time. So this is the prerequisite for the pre-medication. Or you can give inhalation, but we have never tried inhalation. We have tried only inhalation with the local anesthesia. Now the preparation is, sister is now well equipped with the making the lignocaine preparation. We take a big needle, 10 centimeter needle, and around 200 milliliter of lignocaine is taken in a bowl, and with the adrenaline. And actually, the required quantity is not more than 80 to 100, but we prepare 200. And you can see various strength. I won't go in the detail. And here is the most popular with the 100 milliliter, in which the 500 milligram of 0.5 lignocaine is there. And then we give it, the epinephrine also requires 5 to 7 times, 7 minutes to effect. So all this combined should be given so that the proper time, so that it lasts for the effect lasts for the half an hour to 2 hours. And if we give it the bupivacaine, which is another local anesthesia, then it lasts for the 2 to 3 hours. So this is more than sufficient. We never had to actually give, sometimes we have to give the additional anesthesia in this, but this system is foolproof. And there are people who are going to vouch this, that this is a foolproof method, and we are very comfortable while operating and taking out the baby, even suturing in the cesarean section, we are suturing the layers. Then stepwise procedure for infiltration anesthesia. First, professional support with the patient, skin infiltration, and then intravenous injection, then subcutaneous injection in the rectus fascia blockade, then parietal peritoneum and the visceral peritoneum, broad ligament, paracervical and uterine incision and delivery. This is the actually sequence of events how we give. So we are using 10 centimeter big needle, infiltrating like this. We are raising the will like this, and we are raising the adjacent will. We are raising 3 wills so that adjacent area. And I give the arrow like also, so that whenever we are stretching, the patient should not be having pain or discomfort. So this is the most important. And generally, we do not take financial incision, because our indications were such that we have to deliver the baby very quickly. But if there is time and you are very confident, then you can go in for the financial incision. So you have to infiltrate in order to have the local anesthesia, nerve block, and the less pain, and you should have a proper infiltration of the local anesthesia. And after this conclusion of the sets of injection, we have to wait. We have to wait for 2 minutes, hold the incision with the forceps. And if the woman feels a pinch, then again we have to wait. Sometimes I used to again infiltrate little bit of here and there for my own satisfaction. So you can see here, I'm going to show a very interesting video here. So this is the local infiltration being given, and you can see the setting here. This looks like a rural hospital wherein doctor is so confident, and you can see here he is being assisted by only one nurse, and at the head end you can see there is a IOG. So in such a challenging situation, even we have done the same at so many occasions in the rural hospital, like this also we have done. And he is so confident, he is infiltrating for the financial incision and giving it very, very beautifully. And he looks quite experienced and skilled doctor. So this kind of things day in and day out, you can see in the rural hospital, in the women hospital, and even in the big hospital where the anesthetists are not available or they are not on call, and you have to save the patients. So here you can see after the skin incision, he is giving from the above and everywhere by arrow-like manner, he is actually giving the. Now here you can see after the incision, you have to give at least 5 to 10 cc in the rectus sheath with the local. Then only you can stretch the patient while taking out the head. Then you can give the 1 minute. Then here. Then after that you have to give the rectus sheath infiltration. And after that, parietal peritoneum, very, very sensitive. I used to have a lot of difficulty while taking out the head, if the anesthesia is not given properly by my junior, or if you are teaching our junior resident doctors or somebody, so that time I used to say, please infiltrate here. It is a maximum sensitive area and it gives trouble. And here also it is a parietal peritoneum and it is a visceral peritoneum. And if you can see here in the visceral peritoneum, I don't know Pushpa, about the Pushpa and other people, but we had the one small bowl ready of 30 milliliter of local anesthesia. We used to pour it into the abdominal cavity, and once you pour after infiltration, then it becomes, you become very comfortable that even the smallest area is not left, and patient has the infiltration and she doesn't feel pain if you pour it in the abdominal cavity. That is my experience. So this is the visceral peritoneum. So friends, it is nicely given and very confidently given. They are not, I mean, they are doing the cesarean section with utmost, experience, and they are very good at the skill. So when you give aspirate, of course you are not going to, blood should not be there in the syringe, and you should never inject the blood, because there are cases where the convulsion and death has occurred due to the IV injection of lignocaine. And you have to give sufficient time. You should not be impatient. Sufficient time to local anesthesia to act. And these are the popular this thing, incisions mid-level we used to give. We 80 to 90% we used to give mid-level, because the cases were like that, indications were like that. And financial incision nowadays, you have just seen in one of the rural hospital of Maharashtra that financial incision also are being given. So do not use the, what is the precautions. Do not use the abdominal packs. Do not use a retractor, and gentle, use a very small retractor. Even with the fingers also, it is to be if the assistants are good, and avoid any jerky movements or the sudden movements. So these are the positive aspects of the infiltration of local anesthesia, that there are no respiratory complication, no other systemic complication, and baby cries immediately. And we had such a lovely time. Once we send the patient to the post-operative ward, we never used to have a time to go, because we were knowing the patient is not going to have any kind of complication. So it is the minimal disturbance to the cardiovascular system. Majority, so many mothers, they opt for the repeat anesthesia. And I am very proud to say, Pushpa, here that Dr. Sindhu Bhute was to chair the session, whom we operated. She is an obstetrician, whom we operated in the local anesthesia at Akola. And she was, previous LSC, and she had all the facility, but she had such a big trust in us. And she said, you are going to operate me in local anesthesia. And the baby delivered is a gynecologist now. So we are very proud. So don't think that it is an obsolete procedure. It is a life-saving procedure. It is used in the places where there are no resources, there are no anesthetists, and you want to save the mothers. So I think so these are the advantages we already told you. And those people who are actually private patient or other patient, very anxious patient, don't try, because nowadays you have the facility, you can always refer the patient. But those patients who really want, or you require to save their lives, then you have to go in for the local anesthesia. And we are very proud to say we are almost 5 to 7 years, we never had any anesthetist, and we only were doing every cesarean section in local anesthesia. So what are the conditions under which we are supposed to do? Lack of personnel, lack of equipment, of the sophisticated equipment I'm talking about, contraindication, and need for rapid anesthesia, rapidly delivering the baby, and least number of maternal fetal pathophysiology, and proper intubation cannot be achieved in these conditions we are giving. I'm just going to quote 3 studies, the review literature by Dr. Neil Patel and Rizai, that in cases of life-threatening high-risk emergency cesarean delivery is the standard treatment. In some emergency, vaginal delivery is contraindicated. There exists administration of the general or regional anesthesia, and infiltrative anesthesia for cesarean has been previously used where the healthcare funds are less, hospital resources are less, staff are limited, and typically small and rural community, you can go ahead with the local anesthesia. And there are cases which are reported in the journal and published also, that in case of severe osteomalacia, they have done successfully even in the bigger center, and successful delivery of morbid obese patient also has been delivered by S. Patil and Sinha. There are various literature, recommending the local anesthesia, and there is a big series of Dr. Rainey and Sinha that in which they had around 5,000 patients where they were studying the newborns, and 92% of babies cried spontaneously. That is the beauty of this local anesthesia. And the cesarean delivery under infiltrative anesthesia should be viewed as an alternative specific situation, not simply a procedure of historical interest. That is what we are trying to drive the point. And I am going to end with some very interesting facts. You can see here the Women Children Hospital in Maharashtra in Dufferin Fund. What was the Dufferin Fund and what is the connection with the local anesthesia? This is a Kama and Elbles hospital, very popular hospital, 500 bedded hospital in Maharashtra, which is funded by Dufferin Fund. This is a district hospital for women known as a Dufferin Hospital, where Pushpa was the head and I was also heading this hospital, 500 bedded hospital. Then we had this Lady Dufferin Fund for medical training of women educated in colonial India. We had the Daga Hospital, Lady Harding Hospital for Akola. Under this fund, Lady Harding Dufferin Hospital, Kolkata, and Lady Dufferin in Delhi. And there is also the hospital in the Karachi. So what was this fund? This Lady Dufferin was a very noble lady. And when the women were dying in India, that they never wanted to get examined or delivered by a male. That time Queen Victoria requested the Lady Dufferin, whose husband was the viceroy at that time, that please do something to save these women. And then this lady, noble lady, established the Countess of Dufferin Fund, under which all these women hospitals were developed. And what is the common most important thing is that all these doctors are expert in the local anesthesia, because that time only anesthetists were male or something, and the women themselves were conducting the the anesthesia and the delivery. So that is one common thing that is between the Dufferin Fund. So do what you can with what you have and where you are. That is the motto of our life. We never complain to our seniors, ye nahi, wo nahi, we don't have this, but we did it. And we have the living example here, Dr. Sindhu Bhute, Pushpa Thorat, Kamal Deshmukh is the witness who was the HOD of the JJ. She knows our challenges in which we have worked. And these are the beautiful hospitals. You must visit the hospitals. And in my own personal experience of 10 years of working in doing local anesthesia with the 9 to 1100 deliveries and with 3-4 obstetricians, on an average 150 to 200 ANC patients per day we are seeing, and indications for malpresentation, breach, transverse lie, hand prolapse, cord prolapse. These were regular indication. We were so expert. Immediately we used to take the patient in OT, and 20 minutes, 15 minutes used to actually do the cesarean section, come home and again go for the call. So used to attend 5 to 6 night calls also. So challenges were anemia. No blood bank in the site. If you wanted really a blood, then you go to the private hospital, fetch from the private hospital. Then managing PPH was not at all easy. Infectious morbidity was very high, because I have seen so many burst abdomen cases. And even if you operate, there was green color mucus, there was a yellow color, the amniotic fluid was full of pus. And in spite of challenges, we never had many deaths. That was the beauty of it. Because of the local anesthesia, our maternal mortality was very low. Even the neonatal mortality was very low. So friends, it always seems impossible until it is done. And we are very, very proud to say, myself and my generation people, we could save so many lives of the women just because of our little risk-taking behavior. Our seniors were very supportive. They were not making any inquiry and not holding us responsible for any, nonsense thing. And they allowed us to practice, and we were very confident. And in fact, in Gamma Hospital, I have done the local anesthesia cesarean section, and other junior was doing in the spinal, and we compared. So she took 1.5 hours and my cesarean was within 15 minutes. So it is a wonderful.
Beta आवाज नहीं आ रही.
Hello.
Ashish.
So we have a place now. It is not an obsolete procedure. We have a place now for COVID patient, because in the pandemic the respiratory complications are more, and again this art or science is actually returning. And I wish that all the delegates here, 1,000 delegates are attending. You must, if you are working in a big hospital, you must try to do the local cesarean under local, because it is going to help you someday or the other, and you are going to save the patients. So there is a place in the present also and in the future also. So future also, it is not going to be a historical procedure, because we are all sitting here who are doing this. And in Amravati, Dr. Alka Kuthe, and they are telling till today they are doing this cesarean. Even in Yavatmal Women Hospital, Dr. Pushpa Thorat was in Yavatmal. They used to routinely. And when I used to tell in Kama Hospital and teaching, madam, we don't know how to do in the local. We have not seen a, cesarean section in local. So I think there should be a good mix of the experienced people, technologically advanced people, so that we can actually teach our students and the attendee here that step by step how to do the cesarean section. So friends, the take home message is very clear, that it is not a forgetting method of the doing in the cesarean section in local. It can be very well used in high risk patients, especially in COVID period. And you can avoid cesarean and anesthetics complication, and cesarean delivery under implanted should be viewed as a safe alternative method rather than. And I remember that the senior doctor of previous LSA, she said, no, I want to do in the local only, because she was so confident of our surgical skill and trust in us. So I think we have achieved, really satisfied that we have really saved the mothers. And so we have to be brave, we have to take risk, and nothing can substitute the experience. Thank you very much for patient listening.
Thank you so very much, Mandakini ma'am. Indeed, an excellent talk, I must say. Now request Dr. Pushpa Thorat ma'am to kindly.
Let Madam Usha Sharma.
I just want to say that it is excellent, and Dr. Usha Sharma is Madam Shiri, our respected madam.
Madam, I want your comment.
Oh, Mandakini, really, आज तुमने जादूगर की तरह अपना बोला है. Really, it was so nice. First of all, I would like to thank my dear Mandakini, who is chairperson ICOG, as well as Dr. Parul, Dr. Parag, Mitra Saxena, and Dr. Surekha for giving me this opportunity to be with you all on the occasion of FOGSI ICOG online certificate course and lecture series on operative obstetrics. And today's this subject, I really tell you, because I have served all my life in a medical college. So actually, these things are usually almost unknown. But I can tell you one thing, that I'm telling in 1970s, when I was lecturer, when I started this, there were 2 patients like this who were almost in like hepatic failure, and there were so many complications with this. And the anesthetist said, madam, we can't give it anesthesia, and then please do whatever you like. But we said we can't do cesarean section without that. And Mandakini, I can tell you that, as you said, very successfully we did the cesarean section with local infiltration, but certainly we also gave, at that time pethidine was very popular, and we gave pethidine Finargan about half an hour before, but fortunately I did not require to repeat the pethidine. And with that, usually you can finish the cesarean between 15 to 20 minutes, because when you are in a hurry, you always do like this. But as you said, you very corrected, narrated each and every step that we have to go layer wise. Then you don't have to handle much. And you know, I opened the peritoneum with my fingers. I did not force it, I did not, but with the fingers I could separate the peritoneum very easily and took out the baby as soon as possible. Then what happened, that there was no need actually for local anesthesia in many patients, but in other two patients also we tried when we thought that there can be some harm on the maternal fetal pathophysiology, and for the patient it can be risky. So we were, though we were having the facilities of general anesthesia and epidural anesthesia, but we selected this local infiltration. And you very correctly said that even in some obese patient, when intubation is not possible, this is a very good, the only thing that the surgeon should have confidence, number one, and we should always be prepared that the patient, when we are doing the cesarean section, we should not talk much, we should not talk about bad things, because you should care that the patient is listening. So it's really a very good technique, and especially where in rural communities where you do not have good resources, you have very less staff, and you have many other problems, it is really a wonderful technique. And Mandakini, you have really dealt with so nicely कि मुझे लग रहा था अब सारे cesarean जो हैं वो local infiltration में ही करे जाएं. And this is actually when you say that it is the skill of the speaker when she really convince you that yes, cesarean section is possible by local infiltrative anesthesia. Thank you very much, Mandakini. It was really eye-opening and a very nice lecture.
Thank you, madam. I would like to.
For your wonderful comment.
Pushpa Thorat is a person. Dr. Pushpa Thorat should talk because she is doing cesarean section.
Thank you for giving me this opportunity. Dr. Mandakini, your talk is mesmerizing. Actually, we have got in our olden days where there is a what we are doing, that was a challenge for us.
Yes.
Actually, this technique is never taught in our medical colleges, but we have to, this skill is to be developed because of the patients which are coming from, referring from the remote areas, one thing. And with the low resources, manpower is less, but still we have to achieve our target. And you know, and you are knowing that more than 12,000 deliveries per year are taking place, and only one anesthetist for 24 hours round the clock. And it is not possible for each and every patient the anesthetist is available. So this technique we have developed, and it is very, very useful, and we are very satisfied that we have helped a lot to our poor. One another thing I want to tell you that time in the era of 1980 to 1995, only one anesthetic was working, and that time we have published a paper of 100 cesarean section under local anesthesia with no mortality. That was published in conference also. Another thing, public health, there is a EMOC training where the medical officer working at the rural hospital, they are doing the cesarean section. And I think the future of this is this medical officer must be trained in this skill, so that referring to the higher hospital, it and delaying, that will not be there, and it will be very helpful to the patients. Another thing, gentle and very careful handling of the tissue. That is very, very important. And your talk is very inspiring and encouraging to the new generation. At present, our third generation is working in the field and in the era, but this is also a very important step during the cesarean section under local anesthesia in future.
Yes.
I also heard that in Africa, Nigeria, and some of the parts of America, they used to improve this skill so that the patients at the periphery should never be suffer and should not be brought in the moribund condition. So you are very, very I congratulate you. And I think this method should also be given, this skill should also increase. But because the medical colleges there, all the facilities are available and it is not taught, that is the thing. But your talk and our olden and golden days, I remember very, very thank you to you. And I am thankful to the organization for giving me this opportunity. Thank you so much.
Thank you, Pushpa, for sharing. Alka, please just briefly, nowadays you are doing in local, please just briefly tell the audience.
Oh. Okay, madam. Thank you very much for giving me the opportunity. Madam, excellent lecture as usual. And just now reminded me of the, no, it is a forgotten art of cesarean under local anesthesia. But gone are the days when there are less number of anesthetists and the problematic patient like obese patient, moribund patient and having some coagulopathy, heart disease. Sometimes GI is not possible. All these things we used to do with local anesthesia. And today, though the PGs don't know this technique, but I think at remote places, they should know this technique because sometimes we know this is urgent, but no anesthetic is available at peripheral place. So if they learn this technique, and it is a safe technique, you have excellently told what we can do, how to take care, etc., etc. But they should learn this technique in emergency procedure. Okay, we know that nowadays spinal anesthesia is very safe, regional is very safe, and again GA also can be given. But sometimes there can be shortage of ventilator, ICU backup, a remote place. What he will do? So they must learn. So I think that there should be at least 1 or 2 sessions during PG that they will come to know how this is done. So thank you very much, madam, for giving me opportunity. Excellent lecture as usual, madam.
And many times interpretative anesthesia is used for post-operative cesarean scar pain management. It gives a very good response. And as you told, necessity is the mother of invention. But in my opinion, every doctor must know how to use infiltrative anesthesia in cesarean section. That will be very, very useful for their future.
Thank you, madam. Now,
very nice.
Priyankur, thank you very much, madam. Priyankur, please go ahead with the session. Yeah.
Thank you so much, Mandakini ma'am, for that wonderful talk. And I would really like to thank Dr. Usha Sharma ma'am, Dr. Pushpa Thorat ma'am, and Dr. Alka Kuthe ma'am, who have the in-hand experience of this technique for such wonderful comments. And such comments will really help us juniors to think about this technique and take it forward maybe for our patients, which will be helpful for them too. Thank you so much.
Thank you.
So I would next like to welcome our next speaker, Dr. Anahita Chauhan ma'am, who is an honorary consultant at the St. Elizabeth Hospital. She is the former professor and unit head of the State GS Medical College and KEM Hospital, Mumbai, postgraduate teacher for the past 30 years, secretary of the Mumbai OBGYN Society, which has very successfully done the recent conference of MOGS, which was attended by many worldwide. So it gives me immense pleasure to welcome ma'am to this platform for her talk on nuances of evacuating the uterus with respect to MTP, hysterotomy, and GTN. So over to you, Anahita ma'am, for your talk.
Thank you, Priyankur. And if you will allow me to share my screen.
Yes, ma'am, please.
At the outset, I would like to thank Dr. Parag and Dr. Mandakini Meg for excellent programs. Is my screen visible?
Yes.
Yes, ma'am, it is. And you're clearly audible too.
Thank you so much. So the topic which is given to me today by Dr. Mitra Saxena and by Dr. Surekha Taide is nuances of evacuating the uterus. And I have to cover quite a bit of ground in the next 15 minutes or so. I'm going to spend most of the talk talking about MTPs, first and second trimester methods, and then move on to a bit about hysterotomy as well as the vesicular mole. Obviously, if we look at the overview of the preferred methods, we're going to look at first trimester as before 9 weeks and after 9 weeks, and then of course the second trimester methods. When we talk about the revolution which took place in the MTP Act, which was the approval of medication abortion, this is a very important method, but why is it sometimes not so popular? because people misuse or do not follow the standard indications. So of course, gestational limit is extended to 63 days, and we must select patients correctly for this method. Those who have access to healthcare if required, those who are well counseled, only those patients should be given the medication abortion. The adherence to the drug protocol is the most important. And again, ultrasound is not required unless the clinician is in doubt about the uterine size or wants to rule out the ectopic. Once the process is initiated, keep in mind that in case there is a failure, vacuum aspiration has to be resorted to. And of course, we are all familiar with the standard drug protocol, so I'm not going to the details of this, except to say that the current recommendation is instead of 48 hours, we can give the dose of misoprostol as early as 24 hours after the mifepristone. Coming to the vacuum aspiration, and this forms the bulk of the method which is used for the first trimester before 12 weeks of gestation. Of course, electric or manual vacuum aspiration can be used where there is a pre-created vacuum which evacuates the contents of the uterus. MVA was propagated almost 15 or 20 years ago. Do not confuse this syringe with the original Carmen's cannula, which was a single valve syringe with a less capacity and was used only till about 6 weeks of gestation. The current MVA syringe is a double valve syringe with a series of graded cannulas, which also act as the dilators. And this plus MVA plus aspirator, the other important advantage, it can be safely used up to 12 weeks of gestation, and it is autoclavable and can be used almost for 100 procedures. The cannula themselves are easy grip and color coded. You do not require any separate adapters to attach the cannulae onto the syringe. And as you can see, there are flanges which help you to push them onto the syringe. And these are convenient to hold. The advantage of MVA over the traditional electric vacuum aspiration or even the traditional DNC is that it can easily be done under local anesthesia using 1% or 2% xylocaine, giving a good paracervical block, after which the syringe should be assembled and kept on the trolley. And instead of using your traditional metal dilators, you can dilate the cervix with the cannulae themselves. Of course, keeping the same rules in mind, the size of the cannula to be the size of the period of gestation. Once you have achieved dilatation, you can attach the cannula to the aspirator, which is charged and a vacuum has already been created. You then release the buttons to start the suction. Use a very gentle rotatory motion to aspirate the contents. Make sure that you do not pull it out the way we traditionally do with a metal suction. Do not pull out the cannula till you are sure that the syringe is full of the products of conception. And take care to avoid holding the cannula by the arm because it may suddenly lose the vacuum. When the procedure is complete, you disconnect the cannula from the aspirator and you remove the cannula from the uterus. Empty the products into a kidney tray which is there on your trolley. And after inspecting, you may need to charge the cannula again with the syringe and evacuate one more time. So this is just a brief of the steps where you press both the buttons to create or close the syringe, create the vacuum by pulling the piston out till the flanges rest, dilate with the plastic dilator or suction cannula, insert the loaded syringe, release the valve, allow the vacuum to be creating the suction and allow the products to flow into the syringe. The Government of India, along with the Comprehensive Abortion Care Guidelines in 2018, has also included manual vacuum aspiration as one of the most important methods of evacuating the uterus. And this is the checklist which I have taken from the Comprehensive Abortion Care Guidelines of the Government of India. The main advantages of the manual vacuum aspiration is that you can sometimes get the gestational sac intact. Especially if you want to do any tests on the fetus or the fetal tissue, you can use the MVA rather than the electric or the DNC. No electricity is required. And as an extension of the previous excellent talk by Dr. Meg, in smaller settings where electricity is a problem, manpower is a problem, and other issues are there logistically, the MVA becomes an extremely effective portable method for up to 12 weeks of gestation, no anesthesia except local, very early recovery, and patients can leave the center in a couple of hours. Most larger institutes and larger nursing homes will definitely have the electric vacuum aspiration, where it is good for a high caseload. It's extremely safe and effective, and it's one of the quickest ways to evacuate the uterus. It's of course less appropriate for smaller settings where electric supply is intermittent. If you compare the manual and the electric vacuum aspirator, both have equivalent high levels of effectiveness and low complication rates, and the pressure created in the aspirator, the manual aspirator, is equal to the electric vacuum aspirator. In fact, the MVA syringe has a distinct advantage that the vacuum starts decreasing once the syringe is about 80% full. And it actually, there is a slight drop in the pressure. And so even if there is an accidental perforation in an electric vacuum, the vacuum will continue to go on and you will damage something else. Whereas with the syringe, the chance of perforation and damage is extremely low because the vacuum cuts off quite when the vacuum syringe is full. Now, whether you do a manual vacuum aspiration or an electric vacuum aspiration, many people have the habit of performing a check curettage. Now, is this check curettage really of value? And studies have found that it's really not helpful in completing the process or in reducing the risk of retained products. So there are now many people who would just do the aspiration and do not do the check curettage. Of course, just to complete the list of methods in the first trimester, the traditional DNC, but this is a method which is now being phased out even by the government in most of the centers. This method is not recommended for first trimester abortions. So the vacuum is definitely preferred over the DNC because there's less incidence of hemorrhage and cervical injuries, less dilatation is required, less pain, and a shorter hospital stay. Whether you use the manual or the electric or the DNC, there will be complications with all surgical procedures. And incomplete evacuation is the most important complication. Most people think perforation is the complication, but perforation is a dreaded complication. Incomplete evacuation is the more common complication. Of course, the rest of the complications I have listed just to complete the picture. So what's new in first trimester termination of pregnancy? And there are only two things which I thought I could include. One was cervical priming. And though the government regulations say that this is not mandatory, definitely we all know from clinical experience that it does reduce the risk of cervical injury. And ideally, we do use it for nulliparous women, those who have a larger uterus. And misoprostol 400 micrograms can be given sublingually 2 to 3 hours prior to the procedure, or vaginally 3 to 4 hours prior to the procedure. Whichever route you use, misoprostol will cause the cervix to beautifully open up, and it will reduce all the risks of dilatation related injuries. Misoprostol, in fact, if it is given at the correct time, by the time you take the patient in the theater, you can actually see the sac bulging from the os, and it becomes a very simple procedure. What about sonography? I'm not a big fan of sonography, and we must, for the general audience, emphasize that really using sonography to evacuate the uterus is a bit of an overkill. And this should only be used prior, during, or after the procedure in very select cases. For example, you have a uterine anomaly and you have to do an MTP and the pregnancy is in both the sacs. You may want to prime the cervix and the uterus with mifepristone or misoprostol and then evacuate under ultrasound guidance. Or if you feel that the procedure has failed and there are retained products, you want to check and do a repeat procedure. In those situations only, you can use ultrasound. Otherwise, do not take ultrasound for granted for MTPs in the first trimester. Coming to the second trimester terminations, we all know that the reasons for this is there is a delay in seeking services or a delay in access, and of course, diagnosis of fetal abnormalities later in the pregnancy. If we look at all the methods, up to earlier when we were students, we were taught that 12 to 14 weeks is the graveyard and you should not do anything at this point. But currently the use of misoprostol with an MVA will even work up to 14 weeks of gestation. And even up to 16 weeks, mifepristone with misoprostol followed by a DNC will do the job. Beyond 16 weeks, medical methods will definitely be more successful than the surgical methods, and you definitely need some level of skill to perform a surgical procedure beyond 16 weeks. So there's enough international evidence and evidence from the WHO that mifepristone and misoprostol in combination are more effective than misoprostol alone. Of course, it's a two-step process where you prime the cervix, you induce the uterine contractions, and then expel the products of conception. In 2014, the FOGSI ICOG consensus statement also said that 200 milligrams of mifepristone followed after 36 to 48 hours by either sublingual, oral, or vaginal 400 micrograms of misoprostol. And this can be repeated every 3 to 6 hours for up to 5 doses. In fact, we have a publication in Jogi where we have given vaginal misoprostol 400 micrograms every 4 hours. And keep in mind that second trimester is always technically demanding. There are higher complication rates. So you should be very careful when you are performing second trimester. Misoprostol alone also does have success, but not as much success as mifepristone followed by misoprostol. Ethacridine instillation, which we grew up using, is very difficult to obtain. In fact, it is not available to us, but it is also a very safe method, the extra amniotic instillation. Dilatation and evacuation, though even the RCOG guidelines say that you can perform this method, only a highly skilled provider should undertake this procedure because it is extremely challenging and the other methods are easier and safer. So I thank Dr. Jaideep Tank actually for this slide where everything is combined to show that the comprehensive abortion care of the Government of India as well as the FOGSI guidelines are in synergy where mifepristone 200 followed by misoprostol up to 5 doses is the recommendation. Coming to hysterotomy, and I actually did a lot of search to find out whether hysterotomy really is being used. Now, unfortunately, it is still being used in our country. And I say this unfortunately, because a lot of people have a misconception about misoprostol and previous C-section. They think that at 16 weeks or 18 weeks, if a pregnancy needs to be terminated in a patient with previous 2 LSCS, misoprostol should not be used because it will cause rupture. This is not true. The uterus becomes sensitive to misoprostol only towards term. And in the mid-trimester, even in cases of previous C-section, the risk of uterine rupture is really not more than in non-C-section patients. Unfortunately, patients with previous 2 LSCS, where the provider is not confident about using misoprostol or mifepristone, these are the patients where they will resort to a hysterotomy. Sometimes a failed second trimester termination, the provider will resort to a C-section, hysterotomy. And of course, if the placenta is really previa, then it may be better to resort to a hysterotomy. Suffice it to say that it should rarely be performed and it should invariably be performed with a TL. There is no justification to putting a hysterotomy scar on a uterus for a patient who is going to then have a subsequent pregnancy. Modern obstetrics does show a role of resuscitative hysterotomy in a collapsed patient. That is to say, if a patient collapses for any other medical reason and you want to revive her, you may resort to a very rapid hysterotomy to relieve the compression on the large vessels and save the life of the mother. Of course, we are all very excited by the new MTP Act which has been passed, and the same combinations are being tried for pregnancy beyond 20 weeks as well. And now the last part of what I wanted to speak, and I'll take just a couple of minutes, the management of GTN, and I'm going to restrict to a vesicular mole evacuation. And suction curettage is the method of choice for a complete mole. For partial moles, you may want to use a medical method followed by a surgical method, but for complete moles, suction curettage is the method of choice. The medical method should be avoided, and the main reason for this is that there is a theoretical risk that oxytocic agents will cause embolization and dissemination of the trophoblastic tissue through the venous system and even lead to metastatic disease. And data from pregnancies which are managed with MIFI and MISO is very limited, and this should be avoided as far as possible. Anti-D should be given for partial moles, and it is not required for a complete mole. However, if you are not sure, you're just better off giving the anti-D to Rh negative mothers. Unlike first trimester MTPs where we prime the cervix prior to the evacuation, it should be avoided because again of the risk of embolization. Similarly, oxytocin infusion should also be used with caution. Though we know that hemorrhage is known to occur in these patients, there is no role to begin the oxytocin before the procedure. You should only begin the oxytocin infusion after the dilatation is done and you have started evacuating the uterus. This may also cause a profound deterioration of the patient with emboli and other problems. So in cases of vesicular mole, though the hemorrhage can be life-threatening, you should use oxytocic agents with care. Respiratory depression can occur at the time of the surgery, including congestive heart failure and fluid overload. So I'm going to end this presentation with some thoughts about what is the nuances in evacuating the uterus. The first is the correct patient selection. You have to select the patient for medical management in the first trimester or manual vacuum or electric vacuum based on the patient, your facilities, etc. You must have a thorough knowledge of both the surgical as well as the medical procedures. Respect the guidelines, but above all, patient safety beyond anything else. I thank you all, and I would like to tell you that I have taken most of the material from the FOGSI as well as the Government of India guidelines. Thank you.
Thank you very much, ma'am, for the wonderful talk. I would just request Dr. Alka Kuthe, ma'am, she wants to comment on the talk. So ma'am's comments, and then we'll take a couple of lines from Mitra ma'am, and then we'll move on to the panel discussion. So Alka ma'am, your comments, please.
Okay, Priyanka. Dr. Anahita, excellent lecture. So it was a vast topic, but still you combined very nicely all the indications and the procedures which we have to perform depending upon the duration of gestation. Only thing is regarding previous section, previous to LSS, there are still people who don't use MISO for induction or for MTP in previous to LSS section. So this needs to be stressed again that we can use safely unless and until the patient is in the last second trimester, because the MTP Act till now, till death is up to 20 weeks only. So we have to consider up to 20 weeks only. So we can try, but of course the patient should be under observation. So wonderful lecture, Anahita. Thank you very much for giving me opportunity to Dr. Mandakini Madam and Dr. Parag Biliwal. Of course, Dr. Surekha Taide.
Thank you very much. My comments are only just 3 words. First is sorry. From my side and Dr. Surekha's side, we are sorry that we've been greedy in this 3-day course. You've tried to accommodate too many things. We are not doing justice to our speakers, not giving them enough time. But yes, let me tell you, each one of you is giving such pearls of wisdom that all the delegates, attendees who are spending their valuable time here will be benefiting. So my sorry for being a little bit late. Thank you all the speakers for wonderful take-home messages and brilliantly how to manage whatever topic you've been given. Dr. Anaita, Dr. Mandakini, and the other previous 3 speakers. And now the last thing is that please look at the chat box. It is full of compliments and questions. So whatever questions are directed at you, please answer them. And the last line is that the show is still going on and the heat is picking up. So the last session is also going to be very, very thrilling because this is our daily battle. So friends, thank you for the previous 2 sessions. Hang on for the session 3.
Hello, doctor. Hello.
Yes, ma'am. Dr. Pushpa, please.
Hello.
Yes, ma'am. You're audible, ma'am. Please go on.
It is a very excellent talk, though it is a revision for us, but it is a very, very important for the newcomers, you know. And one thing I want to mention here that the tablets, misoprostol and mifeprostol, the inventory control must be there. Otherwise, it can be misused. Yes. That instruction must be given to the field workers. That I want to take you. And the hysterectomy, failure of ethacridine, the hysterectomy along with the tubectomy is the must. This new generation must know all these 2 things. Very, very nicely explained each and everything, madam.
Thank you.
And thank you very much.
Thank you, ma'am.
So thank you so very much, Mandakini ma'am and Anaita ma'am. Indeed, wonderful talks, excellent take-home messages given to our audience present. And I would really like to thank Padma Shri Dr. Usha Sharma ma'am, Dr. Pushpa Thorat ma'am, and Dr. Alka Kuthe ma'am for chairing this session and giving your valuable inputs too. Thank you so much. So I now hand over this session, going to the last session of today's evening, to Dr. Renu Jadhav ma'am from Rewari. So over to you, Renu ma'am, to take it over to us towards the panel discussion on childbirth through normal passage. Over to you, Renu ma'am.
Thank you, Priyanka. I would like to take this opportunity to thank Dr. Mandakini for giving me this opportunity. And now going ahead, respecting the vaginal route, which is the preferred route, I would like you to invite all of you for this last session of the day, which is a case-based discussion of childbirth through the natural passage and troubleshooting, oasis and hematoma, for which I would like to invite Dr. Sujata Dalvi, who is a consultant OBGYN at Mumbai, and and is honorary clinical associate Nauraji Vaidya Hospital and joint associate editor of Jogi, and she is the pulse of the academics. Dr. Ameya Purendare, who is a consultant in various hospitals in Mumbai, and he's also the chairperson Food and Drugs Committee, and he has also in the assistant administrator in the FOGSI Manyata project. So I would like to now invite our panel, Dr. Rajal Thakre, who's Professor OBGYN at NHL Municipal Medical College, Ahmedabad, and who's also a National Coordinator for Adolescent Committee. Next, Dr. Amita Sinha, who is Consultant at Patna and Vice President ISOPAR, and also affiliation with various FOGS and FOGSI ISOPAR societies. Dr. Karthikeya Bhagat, who is Consultant OBGYN at Baby Friendly Hospital, and he's also worked with Dr. Prashant Gangar for initiation of breastfeeding by breast call. And he also made that film for neonatology committee. Next, Dr. Niranjan Shah, who is consultant and a great vaginal surgeon from Kolhapur. Next, Dr. Achla Batra, who is professor, Department of OBGYN at VMMC and Safdarjung Hospital, and who is president Narchi Delhi chapter from 2018 to 20, and chairperson of Urogynecology Committee and various editors of AOGD and Narchi. Now, I'd like to invite Dr. Sneha Bhuria, who is Chairperson, Female Breast Committee, FOGSI 2019 and 21, and Governing Council member of ICOG. And she is a tsunami in the breast webinars. And here, because of her, we are now witnessing such a great advantage in knowing about breast diseases. Next, please. I'd like to invite Professor Sudha Prasad, who is IVF coordinator at Department of OBGYN at MAMC, New Delhi, and who has been awarded various awards and fellowships. She's also Vice President FOGSI. And our own Dr. Leela Vyas, who is the young dynamic person from Jaipur, and she is now she has been former professor and unit head at SMS Jaipur, and is now chairperson ISAR, and has been vice president FOGSI 2018. Next, please. Thank you. And Dr. Reena Vani, who is professor and unit head at RN Cooper Hospital, Mumbai, and she is also chairperson FOGSI Perinatology Committee, and has been president Mumbai Breastfeeding Promotion Committee. And I would like to say she is also the COVID warrior of our FOGSI today. Now I'd like to hand over the session to Dr. Sujata and Dr. Ameya to start the session, please.
Thank you, Dr. Renu Yadav, for a nice introduction. Would request Dr. Ameya to share the screen. Till then, we would like to say and convey our gratitude and thanks to the ICOG Chair, Dr. Mandakini Meg, and ICOG Secretary, Dr. Parag Binewale, and conveners of this program, Dr. Mitra Saxena and Dr. Surekha Taide, for giving me and Dr. Ameya this opportunity to have this panel discussion on childbirth through natural passage, the troubleshooting. Over to Dr. Ameya, please. Ameya, please unmute. Ameya, unmute.
Like Elizabeth Noble said, that however much we know about birth in general, we know nothing about birth in particular. And therefore, we must let it unfold with its own uniqueness. We were always taught as obstetricians two famous words: masterly inactivity. Probably nature takes over any and every form of childbirth as its prime motive of a natural childbirth. And perhaps as obstetricians, we may have to stand back, observe nature taking its course, and thereby allowing natural childbirth. Over the next hour, we are going to discuss about what makes natural childbirth and what, as obstetricians, is our role in ensuring the process remains natural, more importantly, normal. So we have this famous panel of eminent obstetricians from across the country: Dr. Achla Batra, Dr. Rajal Thakkar, Dr. Sudha Prasad, Dr. Leela Vyas, Dr. Amita Sinha, Dr. Kartik Bhagat, Dr. Niranjan Shah, Dr. Reena Vani, and Dr. Sneha Bhuyar, who are going to take us through this journey of natural childbirth. Over to Dr. Sujata for starting off the panel.
Yeah. So with just little introduction of what exactly is a childbirth, Dr. Ameya, the next one, please. It's a low-tech way of giving birth by letting nature takes its course. Mind you, we allow the nature to take its course, but we do intervene as and when it is necessary. So it includes going through labor and delivery without medication, but it includes even pain relievers like epidural. So epidural is also considered as part and parcel of the same, using very few artificial interventions like continuous fetal heart monitoring or even an episiotomy, okay? And allowing women to lead a comfortable delivery and a labor process. And mind you, all this has to be done in a hospital that can deal with any emergency, mind you, because emergencies don't come while banging onto your door. It just comes otherwise also, and you never know when you can be taken over by an emergency. So it should be done in a hospital which can handle all the emergencies. So the next one, please. I would like to ask one of the panelists. We have 3 stages of labor. Of the 3 stages, which stage of labor would you lay more importance to? Yeah, Reena has raised her hand, so maybe we can start with Reena.
So,
We have
Samantha, as Ameya very beautifully said, masterful inactivity and watchful observancy is supposed to be the hallmark of a good obstetrician. So, in the three phases, the first being the phase of cervical dilatation is where nature takes its own course most of the times. The second and the third stage are where we as obstetricians, the stage of expulsion, where the baby is actually coming out. And now we are finding women are now becoming too posh to push and are sometimes opting for elective cesarean so that they don't have perineal damage. But the third stage of labor or the placental stage, according to me, is one of the most important, where if things are not done correctly, is where the maximum complications can occur. So yes, all the stages are important, but the second and the third stage should be given priority. And the last stage, which we sometimes forget, or the fourth stage of observation of 1 hour postpartum, is also important, although it is not focused upon so much in our textbooks also, but that we should not forget, because that's when sometimes we are all excited about the baby and the mother is neglected. So that should not.
Yeah. So thank you so much, Dr. Reena. So as what she said, second stage of labor is basically a climax of the birth, where patient and the care provider needs to be very vigilant as such. International health policy, they've divided some policy and they've given some programming, but it gives more emphasis only on the first and the third stage of management with some guidelines. But so far as second stage is concerned, there are no guidelines as such. What you need is just a skilled care workers and avoidance of any complications, which may at times may not be implemented, but what is the end outcome? If you should have an optimized outcome so far as mother and baby is concerned, and both should be given a proper attention as such. Okay, Ameya, the next one, please. And though uteroplacental circulation is reduced in the second stage, there is a sufficient reserve. Mind you, this is very important to maintain oxygenation of the fetus, and there could be some potential complications like fetal hypoxia, birth asphyxia, failure of presenting part to rotate or descend, maternal exhaustion, or even a birth passage trauma. You need to handle each one of these emergencies with a proper state of mind, and it should be done with a proper intellect. Next one, please. I just want to ask Dr. Karthik, what is the role of partogram in the first stage of labor, Karthik? Dr. Karthik?
I think partogram is the hallmark of managing labor. It works two ways. One is that you know how the labor progresses, and the second is it becomes a medical legal document for you to say it's a graphic presentation of labor. Now, the WHO partogram is quite elaborate. So all you need is to plot the cervical dilatation against the descent. And that is all that is required. So the idea is that if you have a partogram in place, then you know how the labor is progressing, and any deviation from norm is picked up well in time. So I think all labor should be managed with a partogram, and it's essential.
Fine. So I agree with Dr. Karthik that all labor, wherever it is, and it's very easy to have this partogram and to chart this partogram. Even the paramedicos can also chart it along with the help of the medicos. So it should be implemented for any patient who is in labor. Over to Dr. Ameya for the case presentation, please.
So in 2008,
yeah.
Yeah, sure.
I just want to add that not only the passed out, but the students, the partograph is very, very essential because it's the learning process for them. So each and every teaching hospital should have the practice, and I think most of the hospitals are taking care of that. Students should know that how to plot it and how to go about it. Mostly the importance of partogram, we put it at the rural hospitals and where the skilled care birth attendants are using it, and then when to transport the patient to a higher facility. But the students and the resident must know and should be, knowing the importance of the partogram. And at the same time, several studies are now showing that it is not required, but for me, I think it is a must when the students are learning, and for us also, that it is very, very important.
So the editor of the FOGSI journal in 2018 invited Dr. Asha Dalal and myself to write about and to present a critique about the role of the partogram in modern childbirth. And we put it very interestingly. Is it an absolute essentiality or a mere exercise? And we concluded saying that it is an absolute essentiality. Whatever the level of care it is, primary level care or tertiary level of care. Because we concluded saying competent use of the partogram can save maternal and fetal lives by ensuring that labor is closely monitored and that life-threatening complications are identified early and treated in time. Healthcare systems must establish an environment that supports its correct use, and that is where it is an essentiality in training of not just our postgraduates, but also paramedics, and we have made it now mandatory as an essential component of quality care in labor in the Manyata program to have partographic records which are examined. Only when we very, very advertently follow this, the real potential of this wonderful tool that was put forward by Philpott and others and which has been modified subsequently will be totally maximally utilized. So yes, natural labor involves the use of partogram because it tells you what is natural, and when things are going wrong or unnatural, it gives you indications that you need to act or intervene. We start with the first case. So Mrs. S, a primee with a full-term singleton fetus with cephalic presentation, has been fully dilated for the last 40 minutes. Vertex is the presenting part, and the occiput on per vaginal examination is felt at 2 o'clock position. Station is 0. She had spontaneous labor and her activity is 3/10/30 over the last 6 hours. Fetal heart rate is 136. There are no fetal drops with contraction. And on pelvic assessment, it seems an adequate pelvis. Her sonography done recently shows an expected baby weight of 3 kgs, the normal AFI. I would like to ask Dr. Batra, Madam, how would you deliver this patient?
No, at the moment, she has been dilated for 40 minutes and her contractions are, I would say, 3/30 is not really adequate for second stage. So if I would like to augment her if everything else is all right and give her some more time. At 0, I will not do anything else.
Okay. Madam, how much more time will you give her?
After starting oxytocin, we can easily, because 2 hours, we can easily wait. So 40 minutes have gone, so we can wait for another 2 hours. If she gets contractions, good contractions, and the head starts descending, and her, of course, we have to see that her bladder is not full, then we can wait. But if the head doesn't descend with good contraction and for next 2 hours, then I would not like to do vaginal delivery for her at 0 station.
Okay, so you'll wait for 2 hours, right?
After giving oxytocin and wait for her to get good contractions.
Okay. Dr.
Amay, can I add something? Can I add something here?
Yeah.
Amay, see, basically, second stage of labor is quite a pain. You need to understand the second stage of labor. When we say that the duration of the second stage could be 2 hours or 3 hours, depending on whether it's a primary or a multi, you add an hour if there is an epidural anesthesia. You need to understand that the second stage of labor has 2 parts. One is the stage of descent and the stage of rotation. So you would wait in the second stage if the baby is descending. But if the baby has already reached the pelvic floor and it's being pounded on the pelvic floor, then you would not want to wait for a very long period of time. So before you intervene, one is do an abdominal examination, find out whether the head is palpable or not. So if the head is not palpable, that means it is actually engaged and this woman would deliver. But if the head is not engaged, its head is no more than 3/5 palpable, then this is a patient who's probably not going to deliver. Now, in the stage of rotation, you would not want to wait for more than maybe 30 minutes or so, but probably your fetal heart pattern would tell you how long you would want to wait.
Okay. My question to Dr. Amita Sinha. Madam, the patient is not bearing down. I can see the head at the perineum. Do you resort to fundal pressure in your practice? Ma'am, please unmute. Madam, please unmute.
Yeah. I don't prefer to do fundal pressure.
Anybody else or in the panel with a contrary view or something?
If you want me to be honest, I deliver them with fundal pressure because that's what I feel that's what works at times, most of the times. But if you ask me officially, If you ask me officially, no.
I think the previous session had beautifully shown the use of operative vaginal delivery methods, which had been shown both by Nozer and by Suvarna. But the important thing is that it should only be when the head is not palpable per abdomen. So in your case scenario, when the station is 0, the head is definitely going to be at least 1/5 palpable per abdomen. If you think about the palpation by fifths or Crichton's method. But as Karthik pointed out very well, that once there is a bit of descent, we can do it. And I would just like to say, rather than look at specific timings, what we need to remember is as long as there is no maternal and fetal distress, in second stage, we have to be patient. And you mentioned that there was no fetopelvic disproportion, there was no other risk factor. So this is her chance, because the first chance of a vaginal delivery is the best, because once there is a section, although we follow that modified Cragen's dictum, a lot of obstetricians and patients will not give a second chance for a vaginal birth.
Okay. So again, you are emphasizing the golden obstetrician's virtue of patience. Patience is what every obstetrician needs, and an alert mind and eyes to detect any kind of deviation from normal. My question to Dr. Sneha Buyar. Madam.
Actually, I just wanted to add here that we should not think of the second stage of labor from the full dilatation, but it should be actual active pushing. It should be from the active pushing. There we have to count the duration of the second stage of labor. And as Rina has already said, that because the contractions are not adequate, here for this patient, we would like to augment and then deliver this patient.
Okay. So, Dr. Sneha Buyar, what's your take? With episiotomy or without episiotomy? Now the station is +3. It's time for crowning.
I think we have to individualize the case.
What do you do in
till
your
now,
practice?
yes, till now what I'm doing, I'm going to share what I'm doing. If at all I have a primary, basically to avoid all the complications and the extension of the tears, we give as a routine. Even today, though there are some reports saying not in favor of episiotomy, we are still giving episiotomies as a routine for primary gravida, and where we are expecting difficult deliveries or instrumental deliveries.
Okay.
Ame, can I add something here?
Yeah,
See, basically, sure. I feel that the Indian pelvis, probably in Indian women have a narrow pelvis, and probably that's the reason most of us end up giving episiotomies. And I would rather repair a clean surgical tear, incision rather than a perineal tear.
Yes, that's
so
how
I feel episiotomy is very common, and most of the times we end up doing it. But you must do it at the right time, only when it's required.
Okay.
Yes, so that's a very valid reason for giving episiotomies, because suturing is suturing of a clear-cut wound, and of course the chances for sepsis is also less. But then of course, if we advise the perineal massage during the last month, and we wait for the proper crowning of the head, thinning out of perineum, I think we may be able to deliver. But as of now, we are doing episiotomy in difficult deliveries routinely.
So
actually, I won't say that all primaries should have an episiotomy. I think one has to individualize. You can't say that primary, so you have to give episiotomy. If you feel that giving episiotomy would help you, then only give it. In our hospital, we are not giving episiotomies to all primaries.
Okay.
Of course, it comes to 50-60%, but not to all.
Okay. So that echoes what Figo has to say. Yes. That echoes what Figo has to say. The two key words are, instead of routine use of episiotomy, individualize and use the restrictive use of episiotomy.
Yes.
Because you will be able to reduce the number of episiotomies, and also at the same time ensure that perineal tears of major degree are also minimized if you feel that the obstetrician requires episiotomy to be given, especially in unassisted vaginal deliveries. So I think we need to keep these in mind. There is a change in mindset from routine to restrictive, and that is what we need to follow in modern childbirth. Moving on to the second case, this is a patient, 25-year-old primary, who delivered normally with an episiotomy. She gave birth to a 3 kg child with a normal Apgar and was shifted to her room uneventfully. 4 hours later, she complained of severe perineal pain and inability to pass urine. The resident has taken her pulse and she informs us that the pulse is 120 beats per minute and her BP is crashed to 80/60 and she's observed pallor. Dr. Leela Vyas, what is your clinical diagnosis?
This is the perineal hematoma. This is always we tell our student, if patient is unable to pass urine and the pulse also going fast, the BP falling and patient looks paler, it is the hematoma which gives these presentations. So by hearing these all symptoms, we usually take the patient to the some proper examination place. I would like to rather shift to the OT and see the patient and then definite. So this is the sign of perineal hematoma.
Okay. Dr. Patra, do all hematomas need to be surgically managed?
No. This patient, yes, because she has gone into shock. So there must be a considerable hematoma. Otherwise, as a rule, if you ask me, if the size of the hematoma is less than 3 centimeter or roughly 3 to 4 centimeter, patient's vitals are stable, and if you observe it, it is not increasing, then it can be left. But a patient who has gone into shock, definitely we have to manage her and we have to arrange blood before taking her to OT and then see her in OT. Of course, we will examine her in ward, but we'll do a PV and PR, but blood should be arranged before we take such a patient to OT.
Yeah. And also a profile if possible, a quick INR.
PT-CT. We do a PT-CT for all patients who are going to OT and send a patient in
of the
shock.
patient is important.
Protocol is to send coagulation profile, do a hemogram, send a hemogram, blood group cross match, and start fast IV fluids and then take her to OT.
Okay. Can I add something here?
Sorry. What is also important is that not only whole blood, in fact, nowadays we are moving away from whole blood. We also should have either fresh frozen.
I don't think whole blood is available nowadays.
Yes. No, but I'm sorry to say, Dr. Batra, it is, although we are in a metropolitan city in Mumbai, there are times when we don't get the components unless you have asked for it in advance. And in our maternal mortality death audit reviews, we have found that delay in reaching for the components is one of the factors with the Bombay traffic and other things which has actually contributed to the maternal death. So in the preoperative preparation, if you are doing investigations like ultrasound, it should be simultaneously with the management plan.
I don't think we should be wasting time in this patient at least.
Exactly. I don't think ultrasound is required.
But Reena, the most of the time we are getting these blood products ready. But that is to be ordered immediately once you think that this big hematoma, which is leading to the fall in the blood pressure and patient is going into the shock. So usually nowadays we are getting in our city, we are having these all facilities and timely we can get and then only we proceed with that.
Okay, my question was to Dr. Karthik Bhagat. We've all understood that we need to prioritize correcting her hemodynamic imbalance and ensuring that we keep all blood ready and then evacuate the hematoma. Dr. Karthik Bhagat, she's had a full meal after her delivery. She's even had some sweets. Okay. What would be your choice of anesthesia?
See, first and foremost, Amer, let me tell you, the best way to treat a hematoma is to prevent it by proper surgical methods. Second is to pick it up in time. So as Reena pointed out earlier, initially in the program, the 4th stage of labor has to be monitored very well. So if you monitor your patients well, then you'll pick up the hematomas well in time before they become huge and ready to manage in the theater. One of our friends, Dr. Deepak Desai, has devised a method. So he puts 4 alarm clocks on a platform. And he tells the relations. So it's every 15 minutes, the bell will ring. You just call the sister and tell her to see the patient. So this way, at least somebody sees the patient. So if you monitor your patients well, you'll be able to pick up these hematomas. Now, to answer your question, this is a huge hematoma where the patient's blood pressure has dropped. So you need to take her to the theater and repair it at the earliest. So keep the anesthetist with you. Evaluate the hematoma. If you can manage the hematoma with local anesthesia or a little sedation, nothing like it, but with a full meal, probably you'll need to put in a a gastric tube and give general anesthesia, which probably is the best way to manage this patient, because you can't keep on operating again and again.
Okay, very well made points. To
Can I
Dr.
add?
Reena Vani, madam, any experience on the role of balloon tamponade, maybe in small hematomas or vaginal lacerations, etc.?
Ameya, to be honest, the balloon tamponade works better when you're talking about intrauterine or cervical hemorrhage, because the vagina has a huge capacity to dilate. So the balloon tamponade does not work very well. But we have had experience with packing with surgical gauze tied to each other using styptic agents like botroclot or other equivalents. When you feel that the vagina has become very fragile and bruised with attempts, often we get patients who are transferred with attempts at suturing outside and then have come. At that time, when you, after you evacuate the hematoma, you may not be able to find a specific bleeding spot. As long as you're sure there's no cervical tear and all, I am not in favor of balloon tamponade for these cases.
We have used, and I find it better than packing, because when you are removing the pack, it is traumatic for the patient. Balloon is very smooth, and balloon you can distend, you know. It is not that you can distend up to 500, and that will take care of the pressure. If there are lacerations, I'm not talking of a hematoma, but vaginal lacerations, they can be helped with balloon.
Okay.
See, balloon, the balloon works under a restrictive space, with pressure. Now, if you use a balloon in the vagina, then there's no counter pressure for the balloon to act. So if you have a hematoma which you've drained, you've not been able to find a bleeder, then you'll need to pack this vagina. If you're using a balloon, then probably you can use a balloon in the vagina and a balloon in the rectum, which will give you that pressure.
Okay. Dr. Rajal Thakkar, so we've successfully evacuated the hematoma. How would you manage this patient post-operatively? What should you be doing in the post-operative period? So, madam, you're muted. We can't hear you.
I agree with Reena, and that we put the pack. So packing is done. So we need to catheterize this patient, and we need to observe this patient, vitals to be observed, because we need to check whether still there is bleeding or not, because only then with the tachycardia we can make out that if she is getting stabilized or not. So monitoring vitals and putting the catheter. So that these are the two important things. And we remove usually the pack after 24 hours. And even we check for the bleeding also, whether the pack is soaked or not, or whether there is a trickling of the blood from the pack, the vagina also. So we need to monitor the bleeding also, vitals also, and catheterize the blood.
Okay. We all know what OSI stands for, that is obstetric anal sphincter injuries. My question is to Dr. Batra. Madam, could you tell us how we can prevent these injuries?
Well, to prevent this injury, first of all, we have some, prophylactic measures, like it has been said that if you give perineal massage from 34 weeks onwards, or if you give warm packs on the perineum during labor, that will decrease the tears. Plus, when required, you have to give an episiotomy, and not, be strict ki episiotomy doesn't have to be given, because if you give a mediolateral episiotomy in a good sized baby and give good perineal pressure, it will not extend to the anal canal or rectum. So by following this, we can prevent 3rd degree and 4th degree tears. That whenever required, give episiotomy, good perineal support, and that will prevent.
Okay.
Take care of risk factors also. If there are any risk factors, we should take care of. If there is baby is macrosomic, or mother is diabetic, or there is something else, so we take care of risk factors always. If we are going to previous BVAC delivery is there, so to prevent all these things, we have to be alert there and to take care of all those things.
Okay. Dr. Sneha Buyar, how could you quickly tell us how do we repair these tears? Welcome, Dr. Sudha Prasad. Nice to see you. Okay, I think we've lost Dr. Sneha Buyar. We can ask this question to probably Dr. Rajal.
we need to take care of the anal sphincter, so we have to suture that and then giving the full support to the of the muscles. So we need to take it with the 20 or 10 vicryl and then the suture the muscles.
Yeah. So I think the key three words are you need to identify the trauma correctly. Number two, you need to ensure that you correctly repair. So classify, repair, and then you need to ensure that the healing occurs properly in the post-operative period, so as to ensure that
her kneel by mouth and at least liquid diets and etc. So
can I add one thing?
Yes, sure.
I just want to add that when you are repairing sphincter, we have identified, but we have to put one finger inside the anal region. When somebody is tying, the surgeon is tying, one should know how much it has been tied, and it should be the real tender, because I have seen the residents are tying, probably they take the sides muscles, not the right sphincter. So this is very much important. There should be a puckering after the tying. There should be a puckering of anal canal. So it should be made clear that you are holding the right thing. Thank you.
And if the internal sphincter is torn, then that also must be repaired separately by interrupted stitches.
One important thing
to prevent constipation also.
That would be
advice should be there.
So I think
one important thing that you need to remember about the anal sphincter injury is that post-surgery, start giving them Kegels exercise immediately after delivery, so that the function returns faster.
Okay. We move on to the third case now, and we have Dr. Sujata taking us through.
Yeah. Thank you, Dr. Amaya. Would request all the panelists to switch on their videos. We can't see all of them. Dr. Reena, I think Dr. Niranjan Shah, Dr. Sneha Bhulia.
My network is poor.
We would love to see your faces. I'm so sorry to tell you that. Okay, fine. So we go to the next one. She is a 30 years old primary patient. She is at term in a spontaneous labor, admitted. Admission test was reactive. It was a Kefal presentation with vertex as a presenting part. After 12 hours of being in active labor, she becomes fully dilated, fully effaced. Station is -1 to 0. There is no caput, but occiput is at 8 o'clock position. Pelvis is adequate. There is a good uterine activity, and fetal heart sounds are normal. There are no drops with uterine contraction. Would like to ask Dr. Sudha Prasad, since she just joined in. Madam, how will you manage this patient?
Ma'am, I can't see Dr. Niranjan.
No, I thought he was there. Anyway.
No, Dr. Niranjan has just left for an emergency.
Fine. No problem. But we would like to ask Dr. Sudha Prasad, ma'am, how would you go about this patient?
Can you put a slide? I cannot see the slide of the case.
Okay.
Madam, the slide is on the screen actually.
It's on the screen, ma'am. But anyway, Reena, you can take it over.
Yeah.
No problem.
So this is actually a very typical situation. We have to assess, and as was discussed earlier, that we have to look at the partogram. From what you're describing, that if it was 12 hours of active labor, was she in the active phase? Is it a slow progress? It should give you a warning. Station is -1 to 0, which means it could be a problem. We cannot possibly apply, and there is no need right now to apply anything for operative vaginal delivery. What was discussed in the earlier cases, that in the second stage, we are waiting for some amount of descent to occur before the rotation. If at all the descent occurs after augmenting with a little bit of oxytocin or otherwise, if it comes to at least +1, +2, one could apply a vacuum because it allows auto rotation of the fetal head. It was discussed beautifully in the earlier session, and the fact of the matter is the vacuum has the advantage. You can apply it without giving the episiotomy. You're giving a trial for the vaginal delivery. If there is some amount of descent, it will lead to auto rotation of the head, and she is likely to deliver. It's not a preterm baby, so hence I would say
that occiput yes. Is posterior. It's at 8 o'clock. Karthik, I just want to ask you, how long would you wait? This is not an anterior occiput. It's a posterior occiput. So how long would you wait then in that case?
Till the fetal hearts are good or the mother gets exhausted. So 2 hours, it should be fine. So you
Sujata,
occiput
posterior, we talk about the application with the knob being towards the occiput, and it will allow the head to rotate, because 5 out of 6 occiput posteriors, if the pelvis is adequate, are going to rotate to the anterior and deliver. And here is the importance of a good episiotomy when the patient is fully dilated. But the reason why I said I would try the vacuum first is with a higher station, a rotation forceps for occiput posterior is not what anybody would try nowadays.
So when you're applying vacuum, would you like to give us some anesthesia like pudendal block or even in local anesthesia with a good episiotomy? Just want to ask Dr. Rajal Thakkar, would you like to say something? Or maybe Dr. Sudha Prasad can answer this.
Would like to do with under the local anesthesia if I'm doing a vacuum. That is the one we give for the episiotomy.
Episiotomy. And what about pudendal block? Would you like to give if the station is little on the higher side, say 0 to +1, and if you're trying to apply vacuum?
Yes, I would like to give this pudendal block. Yes.
Yeah. Could you just tell us the method how do you give pudendal block? No, could you tell us the method how do you give pudendal block, because most of the people don't know. So Dr. Leela Vyas, if you said pudendal block.
That usually we go with the transvaginal. We just locate the ischial spine, and under that guidance and ischial spine, and then this is notch of the sacral panel. Then we enter and then infiltrate that. Another method is to the transperineal route we used to enter, and with this pudendal block, that all the muscles get relaxed. So even in there are a few indications in which nowadays we are not doing the breech delivery, because one of the indication was the breech delivery, and that time we also used to infiltrate. So give this pudendal block in 2
Fine. Madam, what needle? Would you use the long spinal needle? Yes, so that is very important. You can't use the regular needle, what you use it for local anesthesia. You need to use a very long spinal needle.
Long spinal.
Yes, and you can give it transvaginally. Transperineally becomes little on the difficult side. So transvaginally, if you can feel the ischial spine, becomes much easier. Now, in case the fetal heart starts dropping, Rajal, what would you do? Same patient, fetal heart starts dropping at the time of uterine contraction. How would you go about it? Dr. Rajal?
We try with the left lateral position so that whether it reverts back to normal or not. And if
ma'am, she is fully dilated. She is fully dilated.
We cannot turn her. We cannot turn her out. Then we have to deliver her fast. We have to deliver her fast with the help of either vacuum or.
But it is very normal for the fetal heart to drop during second stage.
Even in the second stage as a vagal.
It will come back to normal, so we should not worry so much.
Fine. Suppose if you have applied a vacuum, when do you call it as a failed vacuum? How many times will you try a vacuum before you give it up on vacuum?
Sujata, here I feel, is either if the cup has slipped off and 3 applications have failed. And the good thing about vacuum is it is a self-limiting device. And once you reach that pressure, it will slip off if it is not well applied. And an occiput posterior, unless you have had what is known as a flexing application and you have attempted to put it as close to the occiput, the chance of slippage is more. Now, the issue is once the vacuum fails, what to do next is the question. If you are pretty sure that the vacuum, although it has slipped, has got the station down a little bit, and now you are able to apply the forceps, which is not going to be mid-cavity, it will be a low forceps or outlet. In that case,
I just want to know
I disagree. One should not do sequential applications. If you have applied vacuum, after that, one should not apply.
Dr. Batra, although there are initial studies which have said that sequential application, which fails, has a higher perinatal morbidity and mortality. But the fact of the matter is, by the time you shift the section,
Nobody should do the sequential.
Yeah, one can do it provided one is confident. I just want to know, when you have applied vacuum, you might feel that the descent has come, but sometimes it's just a chignon which gives you a little bit of feeling that there is a little amount of descent. So you need to check it very well, and then only if at all one wants to apply a forceps, can apply forceps. Anybody for forceps application? Or everybody?
Yes, I think there is a definite place.
Yes.
See, as I said earlier, in such situations, palpate the head. go per abdomen. If the head is palpable at this juncture, then then instrumental delivery is not the way out, and you need to do a section. But if the head is not palpable and you are committed to delivery, then I think a sequential application of vacuum followed by forceps has a definite place.
Yeah, I would say that we should not be giving a message that we can do sequential. Maybe it has been tried, but to give a message to everybody, I don't think it is correct to give a message that you can apply
This is
vacuum
not
and then
a
apply.
message. This is just a way of delivering in case of a good experienced person. And if you have a good neonate team who is standing just beside you, and when you're trying to apply it, we can apply it. It's not that we can't apply it and we just have to give it up. So with consensus between the reviewed guidelines regarding the assigned vaginal delivery, you can use either a vacuum or the forceps depending upon your expertise, and that way you can just allow the process of natural labor to go on. Next one, please, Amaya.
I want to say one thing. There is a standard teaching to the resident that they should apply only one instrument at a time. And when the head is there for a long time, there is a big caput. So probably the resident may be, confused that head has come so much down. Very rightly said that per abdomen palpation is must. And sometimes the bladder is full, you can't palpate it properly. So this is very much important that the resident has to palpate first.
But here in this case, there was no caput. I specifically put no caput. If there was a caput, I would think 10 times even before applying a vacuum or a forceps. But when there is no caput, but it's just that the occiput is posterior and it's taking little time to rotate, maybe one can still try such, because doing even a C-section in the second stage of labor is not all that easy as such. Of course, they are going to discuss it tomorrow, so we will not have discussion today itself. We go to the next one, Dr. Amaya.
Just one point I want to make, keeping both the sides in mind. Please look at the third point in the consensus of these 4 national guidelines. It says discourage the routine use of sequential instruments. And that is what Dr. Sujata Darvi was keeping in mind. You need to look at the expertise of the obstetrician, his clinical judgment, and the resources available both for conducting the procedure as well as the backup of a neonatologist. Routinely, it should not be done. But if it has to be done, an expert obstetrician who can manage such situations or who has managed such situations and is confident and competent to do it, only then it should be tried. Because doing things just because if you have a hammer, you should not put the nail into every wall that you see. So routine use, not justified. Selective use in expert hands, maybe there is a place.
Yes, I just want to add one thing that I perfectly respect what the other panelists have said. And I would again like to emphasize what you have said. If it is a resident who is doing this, we would definitely, in fact, straight away say section. But if there is somebody experienced and the head is not palpable per abdomen and you are confident of your station and position, that is when it can be used.
Again, look at the third point. Each decision should be made on skills, training, and experience.
Yeah, and Veena, nowadays residents are not even allowed to do on their own. They have a lecturer who is fully qualified with them. Otherwise, they are not allowed to do anything on their own. So
I'm sorry, madam, the labor room is taken care by the resident only. Nobody goes in the middle of the night.
We have a fully qualified lecturer all the time.
I'm telling you, this is FOGSI, so you have to look after all aspects.
But residents are not managing alone. It's the lecturers who are fully qualified who are there all the time in the labor room.
Let's move on to the next phase.
We go to the next one.
always
true. We go to the next one.
Nowadays, the residents are doing all these things.
No, ma'am. It's under the supervision of a lecturer who is fully qualified. Now, I would like to ask Dr. Sudha Prasad because she missed out last time. This is a 32-year-old, third gravida, first para with 1 abortion. That was her first trimester spontaneous abortion. She has had 1 full-term normal delivery, male child, 3 years old. And at full term, estimated baby weight at that time is 3.2 kgs. She is in spontaneous labor now. In RR, she comes. Examination, which is done by the resident. Uterus is full-term cephalic presentation, but the head is still floating. Activity is 3 by 10 by 40 seconds. Fetal heart sounds are normal. Per vaginal examination is done in RR. She is 4 centimeters dilated, 50% infestation is little high, and pelvis is adequate. Membranes were present. So she was shifted to the labor room. Amaya, next one. In the labor room, at the time of shifting, membrane just ruptured on its own. So gentle PV was done by a resident who was in the labor room as such, and then he found a cord prolapse with but cord pulsations were still present and very well felt. Dr. Sudha Prasad, management, please. She just shifted from ARA to the labor room and membranes just ruptured on its
So
way.
it is, I'll tell you, whatever the history you have given me, it is 4 centimeter and patient has ruptured the membrane. It is the cord prolapse. This patient requires immediate action. Some residents should put the hand inside, put the sponge inside and put the cord inside, and it should be trolleyed in, wheeled in the operation theater, even though she is a second gravida. If it is 7 to 8 centimeter, the patient should have a forceps vacuum delivery and it should be taken out. But at 4 centimeter, one should not sit for this because head is floating. We do not know, it is a malpresentation. Where is the sutures? We do not know exactly. So in this case, you should not try oxytocin. I won't try. I won't take a chance at all for this. And immediately patient should be wheeled in the operation theater.
But when the resident is shifting the patient to the labor room, what will he do about the cord prolapse? Keeping his hand all the time and while shifting becomes at times difficult. Then what do you do in that case?
You can fill the bladder retrogradely and elevate her buttocks so that, the cord.
Yes, correct. Elevate the buttocks, and maybe you can put a mop and just push the cord inside.
And also fill the bladder also.
Yes,
retrograde will fill the bladder also.
Immediately bladder and the mop. The saline soaked mop should be pushed inside.
Yes. And then
just one point I want to make. I think we've covered the management very well. We have to be more than emergent in our actions, but the predictors of good perinatal outcome have been proven to have 3 factors. One, that the prolapse should occur, the cord prolapse should preferably occur inside the hospital, like it occurred here when patient was in the labor ward. Diagnosis to delivery within 30 minutes, and birth weight preferably more than 2.5 kgs, and mode of delivery cesarean is found to have a better, more favorable outcome. So this was what was put forward in
and you need to have a teamwork. Just 1 or 2 people is not sufficient. You need to have a teamwork. Many people at hand, then only you will be able to get a proper outcome. Yes. Over to Dr. Amay. Yes.
We move on to the 5th case. During delivery of the fetal head, there is delivery of the shoulders. The birth weight, which is estimated, is 3.5 kgs. The pelvis is adequate, but every time the baby is trying to come out, it goes back again. The head goes back again. Dr. Karthik, what's the dreaded complication you are looking at?
You want a live baby without any neural damage.
No. What do you think we are landing up with?
No, we are basically, this is shoulder dystocia. That's it. And you will tackle shoulder dystocia only if you are able to anticipate and you've done the drills earlier. So here the question of drills comes up in the labor room. You can't manage this alone.
So can you tell us the 4 important points in the drill? Simplify them.
The first thing is identification of that turtle sign. The second is, whenever a shoulder dystocia is diagnosed, put the legs up. So that's Mac Roberts. So put the legs up in hyper flexion. Second is somebody should be able to push the anterior shoulder down. So somebody who's standing on the side of the back of the baby will push the shoulder down. Like you are giving a cardiac massage, you try and push the shoulder down. So that's Crystaller's maneuver. Now, if both these fail, then you'll need to turn the anterior shoulder. So the problem is that the anterior shoulder is impinged against the pubic symphysis. So either you rotate it, the anterior shoulder should be dislodged and rotated, or you use both hands and do the Woods procedure. And if all this fail, then you will need to pull the posterior hand out. So you go into the sacral hollow, try and get the posterior hand along the chest and then pull it out, which will reduce the biacromion diameter by 20%. And you'll be able to deliver the baby. Now, all this should be documented. All this should be time bound. And it's best to have a neonatologist and an anesthetist at the time of delivery.
So like you rightly said, it should be done in a sequential manner. one after the other. And hopefully, if you carry out this sequence properly, in more than 50 to 70% of times, you are able to overcome this dreaded, ghastly, dramatic, and extremely scary complication.
And you will be able to do it properly only if you've done these drills in your labor room. And this is where the question of manyata comes up.
Yes.
So if your hospital is...
practice makes everyone perfect. You have to be...
I would like to add that you should tell the mother to stop pushing at that time when you start doing this. You must tell her that don't push now. You have to.
So now we have some interesting special scenarios for you all.
I may get every hospital manyata certified.
Yeah, I'm coming to that a little later. We're coming to that a little later. But
Otherwise,
that, I know my I can see my manyata champions there, so we'll talk about manyata a little later. But we are going to forward some quick for you. Okay?
Yeah. Regarding shoulder dystocia, it should be cleared in all our students, all our PGs, that you're looking towards the weight and all. You should be prepared and inform your senior also. So they should be present at the time of the delivery there. Okay. That is again one of the important part, that big baby, even the multipara they are delivering.
Yeah.
Over to Dr. Sujata. Let us quickly go through.
We'll just quickly go through some scenarios to Dr. Achala Batra. If at all you are called to deliver a patient who is in a breech presentation and she is in labor and maybe she is fully dilated or whatever, and they just call you, how will you manage a patient? If you knew it is a breech, most of them would go in for a section, but sometimes you might land up with an emergency like this, ma'am.
No, multiparous breech don't go into section. Multiparous breech we like to deliver, and we just like this, masterly inactivity for some time. If you get a patient in breech, you have to say it's not footling. If she's not footling, then it's a multiparous with the average size baby, she can deliver. So you let her deliver till her cord comes. Once the cord is there, then you just give a gentle traction on the cord to see it is not short. And after that, again, you wait, let the baby hang by straight till the nape of the neck is visible. And then if the arms are coming fine, otherwise you can deliver the anterior arm followed by the posterior arm. And then the delivery of the head has to be assisted. And that has to be, if you have long forceps, the best. Otherwise, we do a masterly millivet in which we are putting the baby on our arm and then giving malar traction and the assistant is giving suprapubic pressure to keep the head flexed.
Fine. Just want to know one difference. What's the difference between assisted breech delivery and a breech extraction? What did you describe just
extraction, now? Only we do it for a second twin. When the first twin is delivered and the cervix is fully dilated, then at that time, all the deliveries you are conducting yourself. You are delivering the legs, the trunk, the shoulders, everything is done by you. That is breech extraction.
Yeah, Dr. Reena wanted to add
what I would like to just specify, especially for any of the postgraduates, by definition, when we talk about assisted breech delivery, it's where you do nothing until the birth of the umbilicus.
Correct.
Or even if you have done nothing till the birth of the baby till umbilicus, but you have done some intrauterine manipulation, it becomes a breech extraction. So these are important things we have to keep in mind. So if there has been any intervention before the baby delivers up to umbilicus, or there is any intrauterine maneuver, we call it a breech extraction.
And rest of it is an assisted.
Rest is assisted breech delivery. And 2 or 3 important clinical points which have to be remembered is, of course, you mentioned about keeping back anterior. Another thing is, by seeing that the shoulder has the tip of the scapula is seen, that's when you are supposed to hook out the arms. And when you see the hairline or the nape of the neck anteriorly, that's when you do your maneuvers for the head, which means
wanted to ask one more question. Would you give an episiotomy when you're delivering a breech patient, whether she is a multi? Would you give an episiotomy?
Yes.
Definitely. Yes. So liberal episiotomy has to be given for a better delivery of the baby. Yes. Now to Dr. Leela Vyas. This is a twin gestation. One is a vertical lie, and somehow when you're trying to deliver the second of the twins didn't turn out to be a vertical lie. How would you go about it? You've already delivered the first one.
Yes, already delivered the first one. The second breech, already the full dilatation is there. We can do the manipulation, whether it is a transverse or the oblique or the breech. We deliver, and preferably as a breech extraction, we usually do. whether it is a transverse or it is an oblique
That
line.
is if it's a vertical. What if it's a transverse or a
You have to
oblique?
rupture the membrane after correction.
Yeah, first the
That is
rupture the
important. Yes.
That is important. Yes, definitely. To rupture the membrane and that to.
No, what if it's a transverse or an oblique lie? Would you still rupture the membrane and do it, or would you do external?
You correct the lie first and then rupture the membranes.
No, how would you correct the lie? Would you correct the lie with external cephalic? That's what I want to know.
Here is where you would try to do an external manipulation.
Correct.
Try to get the head of the breech, fix it, and here use an assistant to keep that pole on top of the cervix, and then somebody else ruptures the membranes.
And you have to deliver. That is true. Otherwise, the head still goes up.
Yes.
Otherwise, the head goes up, and it is difficult then to get the head in your hand.
So you need help, and you have to have the oxytocin drip in place and rupture the membranes, and then there's a fairly good chance, at least 50-50 of delivering.
One more thing. In case ECV was not possible and baby is still in transverse line, then what do you do? This is second of the twins. What will you do?
IPV.
We have no choice, but in modern obstetrics, people are not doing IPV that frequently.
You're left with no choice. Then what do you do?
Then you can do internal podalic version and
internal podalic version will do and then take out.
Yes, but it has to be done under anesthesia and in the OT. You can't possibly do this in the labor room. Remember one thing, okay? So that is all the message that I just wanted to give you.
Yeah,
over to Dr.
since our residency, yes, in residency they always said. One thing I just want to say.
Yeah, Dr. Leela, tell me.
Anesthesia trolley should be in the labor room when you are dealing with the abnormal lie. This was the principle which we have learned during our residency, because we used to deliver breech in our labor room only.
Very rightly said,
ideally, twin gestation should be delivered in the OT itself, so that in case some emergency arises, you can immediately handle it. With the anesthetist as a standby, of course, and the neonatologist is always there, you know.
We move on to perhaps the last part of this thing, and that is now becoming a fad of natural birth, which is water birth. Let me start with Dr. Sudha Prasad. Dr. Sudha Prasad, you have been a policy maker. You have been associated with the health administration. What's your personal take on water birth? Is it a fad or should we promote it?
I have no experience. In a medical college, I don't think this possibility may be there. If there is a good, fascinating labor room, probably yes, they can do. But not in medical colleges. I have no
universal. It doesn't look like a universal proposition. Dr. Karthik, but you work in a private setup. What's your take on water birth?
I don't do it. I won't promote it.
Okay.
We have only one center in
Mumbai. Who have the experience?
Dr. Reena Vani. Dr. Vani, you worked in the West. The West was the first to adopt this. Okay, your experience and your personal take.
So personally, I don't have experience, but I know of patients who have gone for it. In fact, we had a very famous actress also, I don't want to name who had two daughters who had opted for water birth and this kind of a natural thing. And it has been thought to be helpful. It can be difficult for the obstetrician, but we have a center who is actually offering water births in South Mumbai also and in Bandra also, where they are having these options. And it is believed to be the way forward. In the UK also, water births is a very big market. But here again, it's a question of choice and the facilities. And in case you require to do interventions, it is sometimes a little challenging in case of water birth. So the patient has to be selected well, and counseling and prenatal preparation in the classes to take that informed decision is important.
Okay, so now let me give you some latest analysis. This is a systematic meta-analysis in one of the popular journals on natural birth called as Women and Birth. And it's the largest meta-analysis from the UK. They go on to confess that the experience of water birth is evolving both for the practitioner as well as for the parturient. All individuals involved in the care of women during childbirth, from policymakers to midwives, should understand the possibility for water birth to offer some women a positive experience and memories of childbirth. by increasing the woman's knowledge of water birth as an element of physiological non-interventionalist birth, which supports their baby's transition, may increase their sense of autonomy and control and enhance their experience of childbirth. All this seems okay, but the practical reality is that as clinicians, we should be convinced that it is safe for the mother, safe for the baby, it is practically feasible, and should be judiciously selected in every childbirth, depending upon the patient's demand, the infrastructure that we have. I move on to the next aspect, and that is probably newborn management. We all agree, stimulate first, aspirate second, and intubate third. We need to be very well versed to assess the neonatal condition in spite of us being obstetricians, because a pediatrician may not be there at all moments, and initial resuscitation should be an essential part of obstetric curriculum and obstetric care for the obstetrician. Moving on to Manyata, we know that it's
delayed cord clamping and skin-to-skin contact.
And kangaroo.
Yeah, I'm coming to that. You're already seeing the kangaroo photo here. Okay. I'm going to talk about Manyata. We all know that Manyata is FOGSI's flagship program on providing quality care in childbirth. I start by asking Dr. Sudha Prasad. Dr. Sudha Prasad, do you think that modern obstetrics involves respectful maternity care?
Oh, yes. In a modern obstetric, there should be a respectful, the good counseling of the mother should be there, skin to skin contact should be there like a kangaroo. So immediately the uterus starts contracting and less PPH, we have to save these bleeding to a what is this called? The PPH, postpartum hemorrhage. So this definitely, and we should teach each and every center that there should be, they should add in this modern obstetrics. Definitely, yes.
Every woman.
Final word. Before that, Dr. Leela Vyas. Dr. Leela Vyas, you are one of our Manyata champions who has probably done the most number of assessments in the country, across the country. Are you seeing that there is a change in obstetric care for the better after the launch of the Manyata initiative?
Yes, definitely. Definitely, there has been a big change I've seen, because all the parts, this respectful care, this concept has come. And as with the Manyata program, I would like to say that just change of that face has happened. Usually to scold and all, now the staff is taking care of that. The females, all the Manyata recognized centers, when you go and ask them that, nowadays we are online talking with them, but when we were going, they used to say that their first word is that, Madam, बहुत बड़ा change आया हमारे में. We were not following this thing. We were not allowing our birth attendant. They are allowing. They are taking care of the patients. They are doing. First thing is that how they were performing PV previously. Means no privacy, no asepsis. So these are the things which they have been taken care of that, and all parts. If you go with all the standards, the respectful care has been done, and all they are not of they visit, means if they are visiting to their hospital, they are taking care like that. They are their guests, and they will become their family member for that.
Okay. So, Dr. Karthik Bhagat, everybody is showering praises on Manyata. No doubt that it is making a change towards the better for both clinical outcomes as well as for mental and emotional outcomes related to childbirth. But I want to ask you, you have been also an integral part of the Manyata experience in various capacities. Sir, what is the way forward? Where do we need to improve now?
We need to include all maternity units to be Manyata certified. The idea is to have standardized medical care. See, the problem with us is that most of us have a single owner hospitals, and all of us depend on our staff nurses for maternity care. You can't do everything yourself. There's a huge knowledge gap between the doctor and the staff nurse. by using Manyata standards, you are elevating the staff nurse and giving them confidence. So they become self-sufficient and they are elevated and their self-esteem improves. So one is by doing all this, you are elevating the standards of maternity care, and then it should be considered for every unit.
I think the next step is to make it universally available across the country, universally enforceable across the country, so that there will be a standardization of both quality care and respectful care. And
can I add one thing, Dr. Amya?
Yeah.
Where the 20,000 deliveries are occurring in 1 year. Let's take Delhi hospital medical colleges, where there 20 tables are there and there are 5 residents, and at a time at least 10 deliveries is occurring. So all these, theory remains at one place, and we cannot provide that kind of services where 2 deliveries are occurring. Okay, 2 residents can take care very, very thoughtfully, respectfully. They can talk to the patient, they can tell them to bear down properly and with full care. But I have seen at Loknayak Hospital, Maulana Azad Medical College, I have seen at the Safdarjung Hospital, Dr. Archana, she's here from somebody is there from the Safdarjung. So they can explain the way the residents are working. From one side, the delivery is occurring, and the second side, the patient is pushing and you have to catch that baby, and episiotomy will be done by somebody else. Means, residents, doctors are very minimal in number. So we have to improve that thing first. Then only we can say, yes, we have standardized our labor room.
Madam,
I'll add.
What we need is a change in mindset.
I want to clarify this thing. Amay, can I speak?
Sure. I will clarify if you want to.
Yes. Sudhaji,
so I would like to.
One thing is that where in Manyata we are training our staff. In medical college, what happens? Our staffs are not helping us. Our residents are only working. How it is possible? The 5 residents, the 15 staff members, the nursing staff is sitting outside. They are just standing side by. When the baby comes, they bring the tray and then taking. So we have to improve in medical college also that our staff should work side by side to this, and in hand they have to work. That has to be improved in medical college, and which we are doing in the Laksh. So it is possible if we change our mindset in medical college.
I would like to make a point. I do agree with Dr. Sudha Prasad that our resources are limited and stretched, but we cannot give up. Just as we are not giving up the COVID fight, we are not going to give up here. We are going to make a change in mindset. It will take some time, but we are moving in the right direction. It is not realistic to accept that it will be an overnight change, that everybody will be changing their attitude.
It will take time, but it can be done.
At least we should make an attempt.
That
making the movement in the right direction with the government of India. Both have prioritized this as an essential component of modern childbirth care. And I think that it is very important because, like Susan Arms said, childbirth is an experience in a woman's life, be it rich, poor, from urban, rural area, public place, private hospital, that holds the power to transform her forever. Passing through these powerful gates in her own way, remembering all the generations of women who walk with her, she is never alone. And as obstetricians, we have to hold her hand. We have to make sure that she experiences labor as the most safe, satisfying, and successful experience of her life. Thank you all. This is
thank you very much.
Something unusual.
And myself for having been a part of this panel.
I think Karthik wants to say something.
Something unusual. For Manyata, मैं अकेला जा रहा था जानिबे मंजिल मगर, मैं अकेला जा रहा था जानिबे मंजिल मगर, लोग फिर मिलते गए और कारवां बनता गया.
बहुत अच्छा. Very good. Very good.
We need to get together. We need to change our mindset, and we need to break the first barrier, which is the practicing obstetricians. So we need to come forward and take it from there.
Yes.
Yeah,
Thank
and
you.
whether it be a private hospital or a general hospital, everywhere it should be the same.
Yes, whether it is a big
I think-
hospital or small
I think
hospital,
that is true.
everywhere.
I think if we change our mindset, we do the right
Yes.
things, labor will be as natural as possible, labor will be as normal as possible, and all of us will end up being the most satisfied souls this country can ever have. Thank you so
Yes.
much. Good evening, everybody. Stay safe, stay healthy. And thank you, Dr. Meg, Dr. Mitra Saxena, and Dr. Sujata Taide, and all Surekha Taide, and all the eminent panelists for waiting till so late for this very, very important panel. Thank you.
Thank you.
Thank you.
मॅडम मेघ मॅम तुमचा हे चालू आहे मॅडम तुमचं.
Thank you, Dr. Sujata Dalvi and Dr. Ameya Purandre for this extremely interactive session. And I would wish that all the faculty open their videos and we can have a picture, please.
Yes.
Dr. Leela Vyas, Dr. Meg, huh? Dr. Sudha ma'am. Thank you.
And thank you.
Thank you so much.
Thank you, everybody. Thank you.
Thanks,
faculty.
everyone.
And I
Thanks,
would like
Dr.
to
Meg.
conclude from the ICOG side.
Thank you very much. Enjoyed the panel very much.
Yeah. I would first of all like to conclude the process. Priyanka, you are announcing?
No, ma'am. I just requesting for one more picture. My video was off. Sorry.
Take Priyanka's picture also.
Sudha Prasad.
There.
Sudha Prasad, please show your video.
My internet is very
Sudha
unstable.
Prasad.
My video is unstable.
Ma'am, switch off your audio and switch on your video.
Hello. So now, Priyankar, should I conclude now?
Yes, ma'am. Please conclude.
So the day one has been wonderful start. I can say it has taken up very well. And with the 1 minute, inauguration at the hands of Chief Patron Dr. Usha Saraiya, Dr. Atul Munshi, and Dr. Sadhna Taide was great inaugural program. They gave very, very mesmerizing and also very motivating speeches for the ICOG and all the delegates. And I want to inform everyone here, we got the maximum response. Generally, we stop at 500 to 600 for the certificate courses. But here we had around more than 1,000 registration. And we are very, very happy that both the conveners, Dr. Mitra Saxena and Dr. Surekha Taide did a wonderful job. And I'm getting so many appreciative, comments from the seniors that this program is a need of the hour. And when Dr. Mitra and Surekha contacted me, Madam, can we have this program? I said 100% because it was long due. And there is so much to learn. And today you can see at the 1,000+ registration itself shows the importance. So the first session was excellent. None other than Dr. Nozar Sheriar, Dr. Swarna Khadilkar and Sadhna Gupta from episiotomy to the Forceps to the vacuum. Wonderfully done. I think delegates appreciated their talks and they're demanding the videos. Nozar shown excellent videos of his own methods of doing and do's and don'ts of actually the Forceps delivery. After that, I had the privilege of going from the instrument delivery to the local anesthesia. And actually, I wanted Dr. Sindhu Bhute, who is a sister of Dr. Kamal Deshmukh. She has done extensive work along with me and Pushpa Thorat in the Akula Women Hospital and Amravati Women Hospital. Without any anesthetic, we survived for 5 years. Every day cesarean rate was anything from 2 to 4 to the 6 cesarean section, all kinds of. So they were there, they were witnessing, and I think we are the last breed of people or the gynecologists who have actually done so many cesareans in local, and it was a good experience to tell. And we got a lot of full boxes on the chat box that they want to learn for the emergency, especially in COVID period where anesthesia may be contraindicated or heart diseases. And I am willing to actually teach those who are willing. So we are giving them the number. Myself, Pushpa Thora, Sindhu Bute, Alka Kute, we are many people who are actually experts in local anesthesia. So that is a very practical approach to the subject. After that, after that, Dr. Anita Chauhan spoke very well on the MTP and the products of conception, giving all the guidelines possible. And it was excellent talk, very practical. And after that, we had this panel discussion conducted by none other than Ameya and Sujata. Sujata, both of you deserve this thing, that for even for a normal delivery, you made this so interesting. Water birth and so many things. And what the most important is manyata. And Dr. Kartike Vagat is beautifully narrated in a Urdu shairi that chale the akele karwa badta, log milte gaye karwa badta gaya. And same is with the ICOG also. हम भी चले थे अकेले, सिर्फ पराग था साथ में शुरू में, उसके बाद then we चलते गए. You can see the ICOG family everywhere, and I think Ame is smiling in the cheek. He knows what I'm saying, and he understood what I'm trying to say. And we are such a big family, Ame. I'm so proud. And today, all my mentors, Usha Saraya, Dr. Atul Munshi, everybody was having very high praises. Not that I have done excellent. No, it was such a good concept, teaching, and actually the education to the to the delegates was achieved by this corona time, I must say, and we could do so much, and our creativity was at the peak, I can say that, and a lot of coordination. And when I showed my presentation in the managing committee and governing council, then I found out each and every vice president, each and every committee member, each and every president, secretary, and all the managing committee, even delegates were involved in the teaching. Sudha Prasad madam is the witness to all my teaching activities of online. So I think all in all, it's a great first day. हम लोग थोड़ा पीछे हो गए टाइम में, पर आई कांट हेल्प इट व्हेन पीपल आर टॉकिंग विद सो मच पैशन एंड दे प्रिपेयर सो मच ब्यूटीफुली. सो यू कैन जस्ट स्टॉप देम. टाइम हो गया, अभी आप बंद करो. यू जस्ट कांट स्टॉप देम. वी कांट ब्रेक देयर द व्हाट इन मराठी वी कॉल देयर तंद्री जे असते किंवा देयर पैशन. वी जस्ट कांट ब्रेक दैट. सो सॉरी फॉर बीइंग लिटिल लेट, बट ऑल इन ऑल I must thank you, each and every person, for this wonderful day. Started very beautifully and ended equally beautifully. So I think we part here to meet tomorrow at 5 o'clock and have a good sleep. Stay safe, stay positive, and stay negative for corona. पराग, तुला काही म्हणायचं आहे का? Parag?
नहीं madam, तुम्ही बोला. That is good enough. So everybody must be tired. It's a little late. So thank you everyone, and I must appreciate efforts of our conveners, Dr. Mitra Saxena and Dr. Surekha Taide. They've put in a lot of effort, and of course our favorite Priyankur, who's always there.
You are there, but you are so much present. I can't see you only. So thank you very much. For taking time out and making everybody realize that we are going out of time, but it's okay. Chalta hai, no problem. Thank you very much. And
Okay,
I think
thank you. See you all tomorrow.
See you all tomorrow at 5 o'clock. Good night. Sweet dreams.
सुरेखा एक लाइन.
अच्छा, बोलो बोलो.
सुरेखा.
हाँ बोलो.
सुरेखा.
हाँ गाना गा दे.
चलते हैं, कल फिल्म मिलेंगे.
Before ma'am gives us the parting lines, I just like to welcome all of you for tomorrow's session again. So we will have another exciting session tomorrow, and we have very important topics like the anatomy of the anterior abdominal wall, cesarean section, step by step, troubleshooting and breech delivery. We have then cesarean myomectomy, consent for operative delivery, and another exciting session on adherent placenta, which is a very important topic in today's scenario. Do we need to revisit destructive surgeries, which is again a matter of controversy, videos on second stage cesarean delivery, and an exciting panel on troubleshooting in LSCS. So we'll meet tomorrow again at 5 o'clock. Hope to see you all again today. And our parting lines from Surekha ma'am, she'll do it for us now, and then we'll meet tomorrow evening. evening again. Stay safe. all of
Mitra, which lines?
अच्छा sing अच्छा तो हम चलते हैं फिर कब मिलोगे
जब तुम कहोगे.
कल
That's so true to life.
5 बजे. Okay.
Everybody, thank you so much from the bottom of my heart for joining. Thank you. Thank you very much.
Thank you.
Thank you, ma'am.
Okay, bye-bye.
Thank you, Meg ma'am.
Thank you, Surekha ma'am.
Thank you.
Meg ma'am, thank you.
चलो थैंक यू प्रियंका. मेघ
Priyankur.
डीए हो गई.
Dr. Parag, thank you
चलो
so
good,
much.
well
हमें
done Surekha.
Bye.
Good beginning.
Parag.
Yeah, thank you Renu.
Dr. Harika.
नमस्कार
Renu
डॉक्टर
ma'am.
कुथे. म्युटेड आहात तुम्ही कुथे मॅडम.
Thank you very much, Dr.
Oh.
Parag.
Chan, pleasure to see you. I hope everything is okay with you.
Yeah, better now, better.
Good. Yeah,
But
काळजी घ्या.
God is great.
Yeah, good.
Yes.
Chalo, bye bye.
Thank
Bye,
you, Dr.
Surekha.
Parag. Bye. Good
Chalo,
night.
thank you.
Good night.
Good night.